titulado de la Universidad de Saskatchewan en 1996. Completó una pasantía de animales en pequeños pequeños animales en el Atlantic Veterinary College y realizó una residencia en emergencias y cuidados críticos de animales pequeños en la Universidad Tufts en Massachusetts. Antes de diplomarse por el Colegio Americano en emergencias y cuidados críticos, el 2003 es ex jefe de emergencias y cuidados críticos de pequeños animales de la Universidad de Montreal, esto desde el año 2003 al 2009. Actualmente es profesor titular de emergencias veterinarias y cuidados críticos en la Universidad de Calgary. Es miembro de varios comités del área. Continúa promoviendo activamente el avance en emergencias y cuidados críticos veterinarios, además de ser autor en múltiples capítulos de libros, artículos revisados por pares. También ha sido ganador de premios de enseñanza, investigación y un premio como orador del año. Co-desarrolló el examen FAST original para animales pequeños en Tufts en 1999 y este mismo protocolo se convirtió en el primer trabajo en animales pequeños en ser conocido ampliamente como ultrasonido en el punto de atención, o lo que llamamos focus, así que estamos muy felices de tener al doctor por primera vez, como yo le decía. Hoy vamos a revisar todos los temas de cavidad torácica que son muy importantes en nuestra práctica, no solo como radiólogos, que quizás somos la mayoría de los asistentes, sino como médicos internos y médicos de emergencia, que siempre tenemos que ser, porque obviamente nuestra disciplina es bastante variada y de repente tenemos que ser más histriónicos al momento de estar en la consulta. A veces nos llega una urgencia entre medio en nuestra práctica como radiólogos, así que siempre estos temas van a ser muy útiles de conocerlos. Así que le voy a dar, no los aburro más con mi introducción, le voy a dar el pase al doctor. Doctor, I'm not gonna bore your listeners for much time, so you can start whatever you want.
Perfect. Thank you very much. It is very nice to be included in the lectures today. And we're going to talk about pleural space and lung ultrasound. I will try to talk a little bit slower because I know everybody's not as comfortable in English, and I do talk very fast, especially when I am very excited about the topic I'm presenting. And pleural space and lung ultrasound is a super exciting topic. So I will do my best to slow this down, make sure everybody can keep up. And we'll do this in two sections. We'll take a short break halfway through the lectures, but we are really going to go through pleural space and lung ultrasound. The first part of today's lecture will be the core principles. Then we're going to move into pneumothorax, pleural effusion, and then one of my favorite things, actual lung pathology. So we can actually interpret the lung, even though we can't necessarily see it, which is super exciting. So we do also, if you want more information, we do have a textbook. You can see it here to the left, The Essentials of Veterinary Point of Care Ultrasound, Pleural Space and Lung, that myself, Dr. Shalhoub, and Chris Gomerin published. It's a fairly inexpensive book and focuses on everything on the pleural space and lung. So it goes into more detail than I can cover today. So that is available if you want some more information. But we're going to go ahead then and get started. And why are we? What is the reason that we do point of care ultrasound of the pleural space and lung? Why do we put an ultrasound on our patients? Well, if we look at the veterinary profession, once upon a time, one of the things that we always did, and one of the greatest advancements in medicine, was stethoscopes and listening to our patients. So this was a breakthrough in the 16th, 17th century when they created the stethoscope. Now, not only do we only have the ability to listen, we can put an ultrasound probe on our patients and we can look. So we're unraveling that mystery of the glass box where we had to essentially close our eyes and imagine what was happening by listening. We can now open our eyes and we can see what's going on in the chest. So you can see here that putting a probe on our patient is no more stressful than putting a stethoscope on our patient. So we have the ability now, with no stress to the patient, nothing more than listening, we can look inside the chest. So let's talk about what we're going to see then when we put that ultrasound probe on the chest. So what are we going to talk about today? We're going to start with the core principles of pleural space and lung ultrasound. We're going to talk about normal findings, the key lines and signs that you will see and need to understand when you do ultrasound of the lung and pleural space. So we're going to talk about the back sign, also known as the gator sign. We're going to talk about the pleural line, how you identify that with confidence, and what we can interpret at the pleural line. So we'll talk about lung sliding, also known as the glide sign. We'll talk about A lines. We'll talk about B lines. We'll talk about dry lung. And then we'll talk about my favorite thing to look at, which is the normal curtain sign. So we are going to talk also about the normal curtain sign. All right, so let's go ahead and get started then. The other thing, once we are comfortable with what we're looking at, we can then interpret pathology. So once we know the normal, we can look at 4 key pathologies when we look at the pleural space and lung. These key pathologies, and this is why I like pleural space and lung ultrasound, there are only 4 things we look for. What are those 4 things? Well, the big things we're going to look for when we do our pleural space and lung ultrasound, we're going to look for 2 pleural space diseases. That's it. Just 2 things in the pleural space. Super easy. And we're going to go through those in detail. We are going to look for pneumothorax. That one is harder, but we'll cover pneumothorax. And we're also going to look at pleural effusion. So we're going to look for those 2 pathologies in the pleural space. We are then going to go a step further and look at something really easy, which is pathology in the lung. So we are also going to look at lung pathology. How do we do that? 2 things we're looking for again. It's 2 pleural space, 2 lung parenchymal diseases. In the lung itself, we look for increased B lines and we look for lung consolidations. So that's what we're going to do. 4 simple things that we're going to look for, okay? I'm just going to open up the chat in case anybody has any questions. It says no sound. Hopefully somebody... I can hear you on the English side, absolutely.
Yo les había escrito, I was writing at the chat, que ustedes, si quieren escuchar esta charla en español, pueden elegir el lugar de traducción al lado de compartir pantalla, está interpretación. Eligen el canal español para que puedan escuchar esta charla en español. Okay, thank you, Dr. Soren.
So hopefully everybody can now hear. I just noticed that you had some trouble. Hopefully you found the link to the Spanish and the sounds working in both English and Spanish then. Is it all working, team? Yes. Everybody can hear okay? In English and Spanish? I'll leave it to my translator to say yes in Spanish, or do you just say sí? I do know how to translate yes. Okay. Okay, so we are going to continue then. As we said, we're going to cover two problems in the pleural space. We're going to talk about pneumothorax and pleural effusion, and then we're going to talk about 2 lung pathologies themselves. We're going to talk about increased B lines and consolidations. All right, so first things first, we need to know where we are when we put a probe on the chest. When we put that ultrasound probe on the thorax, we need to know where we are. And this is why it's really important to identify your lung borders. So if I put a probe on my patient, I just put the probe somewhere in the lungs. If I slide backwards, I'm going to run off the lung eventually. And that's going to give us our caudal border. So that transition where we slide off the lung onto abdominal contents caudally, that is our caudal border. That is one of our borders, and that is called the curtain sign. And you can see it outlined here in red. What other borders do we have? Well, if I put the probe on the chest and I just slide straight dorsal, eventually I'm going to slide off the lung and the probe's going to go onto the sublumbar muscles. So this border right here is how far I can go up before I slide off lung. That is our dorsal border, hypaxial sublumbar muscles shown in blue. The cranial border is actually interesting. The lung extends underneath that front limb, but I can't see to the front limb. So that cranial border of as much lung as I can see if I slide forward with my probe is going to be shown here in green, and that is the cranial border. I can make that bigger if I extend the limb cranially. So I will pull that limb forward, and that allows me to look at more lung in that cranial field. Now, ventrally, this is interesting. There are two borders, and you need to know the difference between those two borders because pathology accumulates in different locations, depending on what we want to look for. So we have the ventral pleural border. And if my patient's sternal or standing, then that fluid is going to accumulate in that ventral pleural border where that light blue area is. Now, in some situations, the lung also comes down and contacts that ventral pleural border. However, at the cardiac notch, you can see the lung deviates dorsally away from that pleural border. Therefore, the lung doesn't reach the pleural border in all situations. It's above it where we have the cardiac notch. And that's important because if we're looking for aspiration pneumonia, for example, it will be at the pink border, not the light blue border. So we need to think about, what am I looking for? Is it pleural effusion? Go to the blue border. Is it lung pathology, such as aspiration pneumonia? Then I need that ventral lung border. So these borders are very important. And if you get comfortable knowing all the borders, green, blue, red, and pink, then everything in between those borders is lung. And that's really important because we want to assess multiple regions in the lung for pathology. Okay, so we're going to come back to this over and over because those borders are key for us to find different pathologies and make sure we check the most sensitive spots for those pathologies to accumulate. So that's our lung borders. Now, for those of you that do a lot of lung ultrasound, you know that you can put the probe over lung in any probe orientation you want. It doesn't matter if you are perpendicular or you are parallel to the ribs. You can go perpendicular or parallel. You know what you're looking at, and therefore you can see your borders nicely. Now, if you don't do a lot of lung ultrasound and you've never put a probe on the chest, this can get very confusing. It's hard to know what you're looking at if you haven't done a lot of lung ultrasound. So for orientation, if you haven't done much of this, what we suggest you do is you put the probe perpendicular to the ribs. Put the probe perpendicular to the ribs and you will get a specific image. So start perpendicular, cut across the ribs. You can see that in the image here to the right. We've got the marker towards the dog's head, and we've got the probe slicing across the ribs, perpendicular to the ribs. Okay. Now, like I said, when you're good with ultrasound, you can change and go parallel to the ribs. Then you don't get the ribs in the way. But we need to start perpendicular to get orientation. Okay. So what do we see? What is it you will actually see if you take the probe and you put it perpendicular to the ribs? What is the image we get? Well, if you've not done a lot of lung ultrasound, you'll put that probe on the chest, perpendicular to the ribs, you'll get this image here. And the first time I did this, I was like, what? I have no idea what I'm looking at. Where should I be looking here? Should I be looking here, here, here? Where is it on this image that is the most important spot for me to look at, knowing that most of what I see is artifact? That was very confusing the first time I put a probe on the chest. However, one of the key things you need to remember is there are two main enemies of ultrasound. When we put a probe on a healthy animal over the chest, we get two main enemies of ultrasound. I'll give you guys a second to think about what are the two enemies of ultrasound when we put a probe on the chest. If you guys think about that for a second. If anybody knows, they can write the answer in the chat box. And I'll see if you guys can come up with the two enemies. So so gas is one and bone's the other. Good. Air and bone. You guys are awesome. Those are our two enemies of ultrasound. You put a probe on the chest, you will see bone and air every single time you put the probe perpendicular to the ribs. Now, those are enemies. We can't see those. We can't see through bone. We can't see through air. However, we can use our knowledge of the fact that those are the two enemies to find key structures. So how does that work then, team? This is where we talk about the bat sign or the gator sign. Doesn't matter which one you use. You can use gator or you can use bat, okay? What are we looking for when we say we need to look for the bat or the gator sign? We're looking for two red down curvilinear red lines and one up curvilinear red line. So we're either looking for the eyes of the gator, two eyes, or the two wings of the bat, okay? So we're looking for two eyes or two wings. And then we're looking for the bridge of the nose or the body of the bat. So we're looking for these red lines in our ultrasound image, okay? I like the bat sign because it's what was used initially in the veterinary profession. It's what's used in the human profession, and it makes a really nice acronym. When your probe is transverse or perpendicular to the ribs, you will see bone and air, the two enemies, every single time. So I like the bat sign, bone and air with the probe transverse or perpendicular to the ribs. And we can then superimpose those red lines on our image to help us identify structures. There it is. That's our bat sign superimposed on the ultrasound image. And everything below the bat, if you find the bat, everything below the bat is artifact. So I know then I'm looking at bone and air when I see the red lines. Okay, so there it is again without, there it is with the red lines. Now, how does this work? The easiest thing, if you haven't done a lot of lung ultrasound, find the rib shadow. Everybody can find rib shadows, these dark black areas down here. Trace that rib shadow up until it stops at the bone. That's the surface of the rib right there. That's the wings of the bat. Those are nice because then the first white line below the ribs that joins the rib shadows is the pleural line. Okay, so there it is again. Rib, trace the rib shadow up, you'll get the rib, the wing of the bat. First white line below the rib that joins the shadows is the body of the bat. That's the pleural line. You need to find the pleural line. Okay, this is a really important concept. So we're going to break that. That's my bat flying away there. This is a really important concept. So we're going to spend a little bit more time breaking down what we're looking at. We've talked about borders. We've talked about the bat sign. Let's talk about the bat sign and how it allows us to find that pleural line. So once again, start simple. Start with that rib shadow. Okay, so you start with that black shadow and you trace it up till it stops. That's the proximal surface of the rib. That's the wing of the bat. First white line below the rib that joins the rib shadow is the pleural line. Okay, and that pleural line is extremely important. So that's the pleural line. Now let's break this down in terms of what we see when we put the probe on and we see that bat sign. This is simple. If you put a probe at the skin surface right here where the arrow is, the probe's right there. The ultrasound beam comes down through the subcutaneous tissues, then through the intercostal muscles, and it hits the rib. The ultrasound beam cannot go through ribs, so we see rib shadows. Perfect. I understand that. Ultrasound cannot go through bone. That's why I see the rib shadows. Now, 99.9% of the ultrasound beam is reflected from a soft tissue air interface. So once again, if we look at the image here, we got the probe at the skin. The ultrasound beam comes down through the subcutaneous tissues, through the intercostal muscles, and it hits the soft tissue, chest wall, to air-filled lung, soft tissue air interface. And 99.9% of the ultrasound beam is reflected back to the probe. So I actually don't see anything below the lung surface because the lung is filled with air and air is an enemy of ultrasound. So this is impossible for me to see anything beyond this spot here, okay? So when I put a probe on the chest, if I actually look at what is it I can see when I put the ultrasound probe on the chest, I see this area in green. That's all I see with my ultrasound, the soft tissues and the intercostal muscles. Everything else is artifact. I see nothing that's shown here in brown. This is all artifact. Yet what I really want to see and interpret is the lung, but I can't see the lung because it's artifact. So this is where it's really, really cool. Even though everything below the bat is artifact, if I can find the lung surface, all of our sonographic findings arise from the lung surface. And if the lung's in contact with the chest wall, those will always arise from the pleural line. So ultrasound is a surface imaging technique. And if I can find the pleural line, I can interpret pathology in the lung as artifacts at that pleural line, even though I can't actually see the lung itself. So this is why I think it's super cool. When you put a probe on the chest, we're interpreting artifacts to represent disease in the lung because we can't actually see the lung itself. So I just think that is a very, very fascinating finding that we'll see. So now we've talked about borders. We've talked about the bat sign. We've talked about finding that pleural line and why that's so important. Let's talk about one of the first things we should look for at that pleural line. This is called lung sliding or the glide sign. This one's really important. So if we go back to our anatomy and physiology, you'll remember that you have the inside lining of the chest, the parietal pleura, shown here in white. There's a small amount of fluid between, yep, yes, I can. Okay, no problem. No problem. Okay, glad you can all hear. So once again, if we look at our anatomy or physiology, we have the parietal pleura. This is the inside lining of the chest, the inside lining of the thorax. There's a small amount of pleural fluid that separates the inside lining of the chest from the outside lining of the lung, the visceral pleura. So you can see the two pleura here, and normally there's a little bit of fluid in between them. Now, what happens to those pleura when our patient breathes? When our patient breathes, we take a deep breath. Our chest moves out in cranial, so our parietal pleura moves cranially. At the same time, because the diaphragm contracts, the lungs slide caudally. So those two pleura, the parietal and the visceral pleura, move in different directions at different speeds when our patients breathe, okay? So that's what we're seeing on our physiology and anatomy. Now, how does that relate to ultrasound? If you could put an ultrasound probe on the chest and your probe was sensitive enough to tell me I could see the parietal and the visceral pleura as separate sheets with small amount of fluid in between, ultrasound of the pleural space and lung would be super easy. Unbelievably easy. Unfortunately, the reality is when I put a probe on the chest, I would like to see that parietal and visceral pleura separated from each other, but I can't. Ultrasound is not sensitive.
El ultrasonido no es suficientemente sensible para poder ver ambos separados, así que cuando coloco sonda que vería a ambas líneas como una única línea blanca. Ahora, pleura parietal y visceral no son visibles.
With ultrasound. So how do I know when I put a probe on the chest that I'm looking at the inside lining of the chest and the lung up against it, or if I just have the parietal surface, the inside lining of the chest, and maybe there's a pneumothorax below that? How do I know the lung is in contact with the chest wall? This is where lung sliding becomes key. When my patient breathes, the lung slides across the chest wall. So when my patient breathes, the lung moves. The lung slides. As it slides across the chest wall, it creates a shimmer. So you should all hopefully be able to see the shimmer in this diagram. If I see a shimmer, it tells me two things. Two things have to be present for me to see that shimmer. One, the lung has to be in contact with the chest wall, and two, the lung has to actually slide or move. Therefore, the patient must breathe. So if I see lung slimmering or I see lung sliding, what does it tell me? It tells me that the lung is against the chest wall, moving back and forth with respirations. So when I see a shimmer, I know one, that the lung is in contact with the chest wall, and two, it happens when the patient breathes. So if your patient's apneic, and it's only breathing once every 10 or 15 seconds, you will not see lung sliding till the patient breathes. For that 10 seconds between breaths, you will just see a solid white line. It's the movement that you see when you see lung sliding. So we don't see the lung itself, we can interpret that it is there because we see that lung sliding, okay? So what does that look like in a real patient then? Here you have the lung sliding on the left, here you have an example of that on the right. So let's go ahead and break this down. What am I looking at? Lots of lines in here, lots of different things happening. Look for the rib shadow. Trace the rib shadow up till it stops. That's the rib. Look for the first white line below the rib that joins the rib shadows. This is coming off the rib, it doesn't count. This is the first rib or white line below the rib that joins the shadows. That's my pleural line. Now, hopefully you can all see that back and forth horizontal shimmering of that pleural line. And when you look for shimmering, ignore everything else on the image. The patient's breathing, the muscles are contracting, there's lots of movement everywhere above and below the pleural line. Ignore everything. Nothing exists when you look for lung sliding except that pleural line. And when you concentrate on just that pleural line, look for horizontal, back and forth, left and right, shimmering. Not up and down movement, not in and out movement, nothing below or above the pleural line, just look at the pleural line. Can you all appreciate that there is shimmering here? Give me a yes or a C in the chat box. Yes, excellent. Perfect. So you can all see the shimmer. Now, what does this look like? To me, it looks like the tap water. If you turn on the tap, you don't really see the water moving, but you see shimmering as the water moves, which tells you the water's moving. Same thing, you're looking for this tap water shimmer along that pleural line, okay? Now, that is our lung sliding or our glide sign. That one's key, and we're going to come back to that over and over again. But just to round this out and complete our normals, let's talk about A-lines. So we talked about borders, bat sign, pleural line, lung sliding. Let's talk about A-lines. What are A-lines? A-lines are equally spaced, horizontal, parallel, echogenic, or white lines. So if I look over here on the schematic, I can see these parallel, echogenic, white lines. If I look in the image here, the still image, I can see A lines that are slightly curved in this image here. They are parallel, white, equally spaced lines, okay? Now, what creates an A line? Why do I see A lines? Well, if we come back to what we know when we put a probe on the chest, this is why it's so important to know bone and air. I put a probe on the chest, we know that there's soft tissue up here, everything down below that pleural line, that soft tissue air interface is artifact, rib shadow, and air-filled lung. Now, A-lines, I really like A-lines because they always occur below a soft tissue to air interface, okay? So they occur below a soft tissue interface. So this is the soft tissue air interface that you see here in our schematic right at the pleural line. This is the soft tissue air interface we see here in the still image. That's our soft tissue air interface. So again, if I come back to and put a probe on that chest, I come back and I put the probe on the chest, the ultrasound beam comes down through the subcutaneous tissues, through the intercostal muscles, and it hits the soft tissue air interface. As we said, 99.9% of that ultrasound beam is going to be reflected back from that pleural line. And that will register that pleural line by the ultrasound probe. So there it comes down, bounces back, boom, I see the pleural line, excellent. The ultrasound probe is highly reflective. That ultrasound beam is bounced back from the probe. Some of it's absorbed, and that's why I see the pleural line. But a lot of that ultrasound beam that gets back to the probe, because the probe is reflective, will bounce back down to the pleural line. So what happens is it bounces down, hits the pleural line, because it's a soft tissue interface, bounces it back to the probe, and now the probe thinks it sees a second pleural line equidistant because it took twice as long for that beam to bounce back and forth twice. So now it thinks it sees a second pleural line in the air-filled artifact of air-filled lung. So that's the A line, and that probe ultrasound beam keeps bouncing back and forth, creating multiple A lines in that air-filled lung. Okay, so you can see it here in the schematic. Same thing over here. There's the pleural line, bounces back and forth once. I see the pleural line. Bounce back and forth twice. I see a second pleural line. That's the A line. Bounces back and forth 3 times. I see an additional A line.
Hola.
Just
Disculpen, no se escucha el audio, no se escucha el traductor tampoco.
All right. So, yeah. Yeah, I can hear you.
Hola Carolina,
sí,
son algunos computadores parece porque nosotros los estamos escuchando súper bien.
Okay, so is this working okay?
Yes, we're listening. Le estamos escuchando bien.
Okay.
Hay algunas
sorry,
personas que no
hopefully it will also be recorded. And if it's recorded and the recording is audible, if anybody misses anything in the live presentation because the recording's not going well, you should be able to watch this on demand and you should be able to listen.
Tras demanda y podrán escuchar cualquier parte que no pudieron quedar claro. Si se está grabando, deberían poder grabarse en inglés y en español. Y será de utilidad si es que no me pudieron escuchar en vivo. Porque pareciera funcionar para muchos.
Okay, so if we continue then, this is why I think A lines are really important to understand as well. A stands for air, okay? So A lines occur at any soft tissue air interface. So will we have A lines with air-filled lung? It's a good question. What is in the lung mostly in a healthy lung? Air. Therefore, we have a soft tissue to air interface in healthy lung. Therefore, we see A lines. A lines occur at any soft tissue air interface. What do you get when you have a pneumothorax? What fills the pleural space when you have a pneumothorax, team? Anybody want to answer that? What fills the pleural space when you have a pneumothorax? Air, exactly. Thank you very much. So if you have air in the pleural space, do you still have a soft tissue air interface? Yes. Therefore, do you still have A lines visible when you have a pneumothorax? And the answer to that is yes. A lines are visible when you have air-filled lung because you have a soft tissue air interface. A lines are visible when you have a pneumothorax because you have a soft tissue air interface. So you will see A lines with both normal air-filled lung and with a pneumothorax, okay? A lines do not help us tell whether there's a pneumothorax present, yes or no. They are there in both air-filled healthy lungs and pneumothorax. But here's an interesting question for your team, and I'll wait for somebody to answer this one as well. Do you have lung sliding when you have a pneumothorax? So if we have a pneumothorax, will you see lung sliding or glide sign? And the answer is no. Perfect, team. So we will lose that lung sliding, and there are three main causes that pull the pleura away. Remember, for lung sliding to be visible, the visceral pleura or the lung has to be against the chest wall because it's the movement of the lung along the chest wall that causes the lung sliding. There are three things that will pull the lung away from the chest wall and remove the ability to see lung sliding. So we lose lung sliding in three major problems. There are three major things that separate the pleura. What are those three things, team? Pleural effusion pulls the pleura away from the chest wall. We don't see lung sliding along the chest wall. Pneumothorax pulls the lung away from the chest wall. We no longer see lung sliding at the chest wall. Pleural space diseases that occupy that area, such as masses or diaphragmatic hernia, pull the lung away from the chest wall, and we lose that lung sliding. Okay, so those are three big things that we lose lung sliding. So if we look at this answer now, on the left over here, again, we see that rib shadow up to the rib. We see the first white line below the rib that joins the shadows. We see lung sliding here. This is air-filled healthy lung. We see lung sliding. This patient does not have a pneumothorax. It has air-filled lung. If I look over here, there's my rib shadow coming up, stops at the rib. First white line below the rib that joins the rib shadows right here. Now I'm looking at that, and again, when patients have a pneumothorax, they're still trying to breathe. They don't stop trying to breathe. Everything's still moving because the intercostal muscles contract. But if I look at that pleural line right there, team, I see up and down movement. It may shift in and out. Don't care. Do you see obvious horizontal shimmering along this pleural line? And the answer is the pleural line's moving, but it ain't shimmering like white water from a tap. This is a patient that has pneumothorax. It is the hardest thing to diagnose, pneumothorax. So we're going to come back to some of the other things that will help us diagnose a pneumothorax after we finish normal lines and signs, okay, when we talk about pathology. So we will come back to pneumothorax. All right. What else do we have? B lines. B lines are also referred to as lung rockets, comet tails, and ring down artifact. Lots of names for the same thing, essentially. So we're going to, just to keep it super simple, we're going to call them B lines, okay? When do we see B lines? We see B lines when there is less aerated lung at the lung periphery, okay? Whenever the lung density decreases or increases at the periphery, when the lung density increases at the lung periphery, which means we have less air in the lung at the lung periphery, we will see B lines. They occur naturally in 11 to 50% of cats and dogs, okay? The more lung surface you scan in a healthy animal, the more likely you are to find a B line. So when do we see 11%? If we're only scanning 4 sites on the chest, like the original vet blue protocols, then we're only going to see it in 11% of healthy dogs and cats. If we scan more rib spaces, like they do with the study that came out by Vazzosi in Italy, then we're going to see it in a lot more locations, in a lot more animals. So we'll see it in 50% of healthy cats and dogs, depending on how much lung surface you scan, okay? But it's a normal finding. We'll see it in most of our healthy cats and dogs. If you put a chest or you put a probe on your chest and you scan yourself, most of you, if not all of you, will have at least one site where you can find a B line. So they're a normal finding. And for those of you that are Star Wars fans, these look a lot like, according to my colleague, these are going to look like, I can say, so vertical white lines. we're going to go through the exact specifics of what a beeline entails. So there is a question in the chat box. Does M mode help you detect pneumothorax? If you're not sure you see lung sliding in B mode. It's a great question, and I'll come back and answer that at the end because I do have a specific clip on that. And yes, in some situations, M mode can be helpful. The big problem we have in our veterinary patients relative to dogs is we can tell humans to just take a deep breath without moving otherwise, so that the motion occurs only at the pleural line when the lung moves. And then you get this change down below the pleural line. The problem with cats and dogs is they're often moving, and therefore you'll see motion above the pleural line, which prevents us from seeing the lung sliding with M mode. But I have a nice clip of that at the end, and since you've asked the question, we don't use it very often, but we have used it occasionally, and I'll show you what it looks like at the very end. Once we've gotten through the entire talk, I'll come back and put those clips in for you. I'll just have to find them. Okay, good question though. All right, so what are the exact criteria for beelines then? How do we know that it's truly a beeline? So our normal criteria are occasional is normal. As we said, put a probe on a dog or cat, you will likely find at least one beeline somewhere on that side of the chest. So occasional is normal. They are vertical white lines. A lines are horizontal, B lines are vertical. Vertical white lines, okay? And they have to be white. A lot of people see any movement in a clip and they think, oh, it's vertical, it must be a beeline. It has to be white. If it isn't a white vertical beeline, it's not a beeline. If it's not white, it's not a bee, okay? It's got to be a vertical white line, and it's a really obvious white that you see, as you can see in the image here to the right. Vertical white lines, okay? Now this one's key. They originate at the lung surface. All beelines have to originate and extend vertically from the lung surface, okay? Therefore, in this image, we can see a beeline. And that beeline originates in this image at the pleural line, which means if it has to originate from the lung surface, if I can see it at the pleural line, it means the lung is in contact with the chest wall. All beelines always originate at the lung surface when we can see them with ultrasound. Therefore, if I can see a beeline, it rules out pneumothorax at the location I see the beeline. Okay, so beelines eliminate the possibility of a pneumothorax where I see them, especially if they're against the pleural line, because they always originate at the lung surface. And if I can see the lung surface, it means there's no enemy above the lung surface, means there's no pneumothorax there. Beelines rule out pneumothorax. Okay, now this one's also important because a lot of people have trouble differentiating artifacts from beelines. Because beelines originate at the lung surface, it means when the lung slides, beelines will always move horizontally with lung sliding, okay? If you look at it and you see a vertical white line that doesn't move at all as the patient breathes, it's not a beeline. Beelines always move in sync with your respirations, okay? And we'll show you some artifacts later, like Z lines or Z lines that don't move, and therefore are not beelines. They're an artifact that have no relevance. We'll come back to that. So it moves with the pleura, usually extends to the far field. If I look over here, I can see that this depth is at 7 centimeters. It's a little bit dark down here. The gain could be turned down a little bit, but once I see a beeline, I can now see that that beeline extends
Que
to...
esta línea B se extiende hacia el campo derecho. Lo verán visible en campo lejano, así que las líneas B usualmente se extienden a profundidad. Y si tengo líneas A visible, como no verán aquí, pero si hay visibilidad de líneas A, las líneas B. Estas son las líneas B. Hay 5 criterios que se usan. Son verticales, desde superficie pulmonar, se mueven con la respiración, se extienden a campo profundo y tapan las líneas. Entonces, excelente. Ahora hemos cubierto márgenes, signo de murciélago. Hablaremos del pulmón seco. ¿Cómo sabemos si colocamos sonda que ese pulmón mal aspecto o anormal? En otras palabras, patologías dentro del pulmón. Así, lo primero que hay que hacer es evaluar pulmón como normal o anormal. Hay que asegurar que este sí entre en contacto con pared torácica. ¿Qué hay que buscar para decirnos que esté en contacto? Hay que buscar deslizamiento pulmonar o signo del deslizamiento. Si veo el signo, sé que el pulmón está en contra o interpretar la superficie del pulmón por anormalidades. Hay que primero siempre buscar deslizamiento para ver si es normal o anormal. Todos lo vemos, este deslizamiento y destello horizontal. Bien, entonces hay contacto, puedo interpretar. ¿Qué hay anormal? ¿Qué se considera normal y anormal? Es considerado normal. Si veo deslizamiento y veo menos de 3 líneas B en esa ventana, probablemente esa superficie pulmonar esté normal en ese punto. Lo que se tienden a ver en muchos sitios, si tomo sonda y la coloco en el tórax de un perro o gato y escaneo ese tórax completo, esa mitad completo de tórax, muchos lugares que escaneo en ese hemitórax completo con diferentes sitios, muchas veces veo deslizamiento pulmonar y solo líneas A. Áreas serán de deslizamiento pulmonar y líneas anormales. En muchos perros y gatos, como dije, un 50%, dependiendo de cuánta superficie pulmonar se revisen, tendrán una ventana con línea B. Es común para mí, al menos, ver en algún punto en ese pulmón un sitio donde hay una línea B. En algunos animales veo incluso 2 líneas B. Así que escaneo ese hemitórax, veo líneas B en ningún punto, y justo ahí una ventana con 2 líneas B y hay otra ventana con 2 líneas B. Ocasionalmente es menos común, pero a veces veríamos 2 líneas B en ubicaciones únicas o 2 ubicaciones en un mismo hemitórax. Ahora, aunque es poco frecuente, es posible ver 3 líneas B en una ventana en un gato saludable. Es muy raro, pero es importante en gatos y perros saludables que si escanean suficiente perro gato, si escaneen bien un hemitórax por completo, encuentren 3 líneas B en una única ventana en este animal saludable. Ahora, si los veo, hay presencia de deslizamiento. Menos de 3 líneas B significa que ese pulmón está seco o es una superficie normal en ese punto de sondeo. Es importante recordar que hay que evaluar cada ventana, cada punto de sondeo, pero también hay que agregar todas las ventanas de un lado del tórax. Así que vemos cada ventana si es normal o anormal. Después vemos múltiples ventanas y después dirán, bien, todas estas ventanas en conjunto es anormal o anormal. Así que veamos el ejemplo de cómo se hace algo así. Aquí tenemos paciente, mostraremos múltiples sitios, haremos un protocolo de escaneo en forma de eso y veremos múltiples sitios dorsal, medial y tercio ventral. Así que vamos por los
and the middle regions of the lung. And if I see lung sliding in all those windows, and I only see A lines and nothing else on this side of the chest, then each window is normal, and this entire hemithorax, this entire side of the chest, is normal at the lung surface. Okay, so this would be a normal finding. What about this case here? I put the probe on, I'm scanning multiple sites, I have lung sliding at each site, and in one site, only one site, I see 3 B lines. Is this patient normal or abnormal? If I see 3 B lines at only one site. Well, if we look at the literature, it's rare, but I might see 3 B lines at one location. So now I have to think about the patient. Always think about the clinical findings and the overall clinical picture. If this patient was scanned, and when I scanned it in the morning, and he's in my ICU, and everything was completely blank or dry. So if I scan the patient in the morning and all those sites that I assessed look like this, perfectly normal. Then I put that patient on IV fluids and I rescan that patient after I put him on IV fluids, and a site that was dry now becomes wet. So if I put a patient on fluids and he goes from this to this, I'm worried. I should not see B lines develop while my patient's on fluids. It worries me the patient's in volume overload. So in that situation, 3 B lines, even though if it was only at one site, would be worrisome. If this was a dog that came in for vaccination, 8 months old, no history of respiratory problems, no other issues at home, he just comes in for a vaccination and he's otherwise healthy, and I see 3 B lines at one window, it's probably normal for that dog. You gotta think about it in clinical context, okay? It might be abnormal. For example, if it develops while a patient's on fluids, but it might also be normal if that patient has no other problems, and it might be a normal finding at that one spot in that particular animal. Okay. What about this case here? I'm scanning every window. They all have lung sliding, and I see one side here with one B-line. That's all right. One B-line's no big deal at one spot, not worried. Looks normal here, looks normal, looks normal. Yeah, I got one spot with two B-lines. That could be normal in a dog or a cat to see two B-lines at this window. I come down here and I see a third site now with two B-lines. This is where it gets interesting. Each site could be normal. I can see one or two B-lines in a window of healthy cats and dogs. But now I've got three sites that are positive on this side of the chest. More than two sites that have B-lines, regardless if it's one or two, if I have more than three sites, three or more sites on a chest that contain B-lines, I'm worried it's pathology. So even though each window's normal, the total number of windows affected makes me worry there's pathology. So think about each window and think about all the different windows added up. Anytime you get two or more sites that are positive, you should be worried that there's pathology, okay? So last one here, team. I scan this patient and I see this finding. I got nothing here, nothing, 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 nothing. 4 B-lines at this window. What do you guys think? Is this guy normal at the lung surface, or is this a concern that we have a problem in this patient based on these particular findings? What do you guys think? I'll wait for somebody to say normal or abnormal.
Abnormal.
Excellent. I 100% agree. And why is it abnormal? Because even though only one site's affected, that one window has multiple B-lines. I've got 4 B-lines there. That's a problem. This patient should be concerned for pathology. Okay. So now, team, we've covered everything. I'm going to talk about my favorite thing to look at when it comes to pleural space and lung ultrasound, and that is the curtain sign. Curtain sign is something we'll find in all of our healthy patients. It is simply that border where we're going to slide from lung onto soft tissues. So for example, I put the probe here on the patient, on his chest. I'm going to see ribs and I'm going to see lung. I'm going to see my normal bat sign. And I'm also going to see lung sliding at this site. What happens if I slide the probe caudally along the lung until I am half over lung, half over soft tissues of the abdomen? What does it look like right here where I'm half over lung, half over soft tissues of the abdomen? So what does that look like then, team? So I've drawn the ultrasound probe on the x-ray, half over lung, half over soft tissues. So here's my schematic here with the ultrasound probe. This side over here to the left, this is lung. This side over here, this is abdomen. Ultrasound beam comes down from my probe. It hits the rib, I get rib shadows, I don't see anything. Ultrasound beam comes down, it hits air-filled lung. 99.9% of that beam's bounced back, I don't see anything. So this is our normal rib shadow and lungs. Okay, what happens on this side? The ultrasound beam comes down. It hits the rib, I get rib shadow. Ultrasound beam comes down through the soft tissues. It's going through the subcutaneous tissues. We're going through the intercostal muscles, and I hit soft tissue. And then I hit the soft tissues of the abdomen. That ultrasound beam continues. So when I am exactly at that border, half over lung, half over abdomen, I get this image here. And what does it look like when the patient breathes? That's my curtain sign, team. Okay, we're vertical edge artifact, where you're half over lung, half over soft tissues. And this vertical edge artifact is really interesting. And what we can do is we can say that this here, this vertical edge that I see, tells me I'm at the caudal border. And when my patient breathes in, that curtain sign moves caudally on inspiration and cranially on expiration. And the abdominal contents, when the diaphragm contracts, moves caudally on inspiration and cranially on expiration. This is important because if I understand the curtain sign, I can start to diagnose lung pathology, including pneumothorax, when that becomes abnormal. So I'm going to show you an example of that. So I really like the curtain sign because it tells me exactly where I am. I know exactly where the probe is located. I'm not going to mistake the abdominal contents for lung pathology because I know what the curtain sign looks like. And I can actually diagnose pleural space and lung pathology by assessing that curtain sign. Okay. So again, in a schematic, what does it look like? We're half over air-filled lung on the left, half over the soft tissues of the abdomen on the right. It gives us this vertical moving edge artifact. All right, excellent. A lot of people say, well, is that vertical edge the diaphragm? Is this the diaphragm that I'm seeing here? And the answer to that is no. The vertical edge is an artifact. because air-filled lung overlies soft tissues of the abdomen at the costophrenic recess. So if you think about that, the diaphragm is actually running along here between the soft tissues of the abdomen and the chest wall. It's actually this little black line that I see running right in here. That is the diaphragm. And as soon as the diaphragm curves away from the chest wall, like on an X-ray, what fills this space in a normal animal? As soon as that diaphragm curves away from the chest, what slides into the costophrenic recess here? Air-filled lung. So air-filled lung will prevent me from seeing the diaphragm as it curves away. So you will never see the diaphragm curve away from the chest in a healthy animal, with one exception. And that is when you're down at the pericardial diaphragmatic window. So you'll never see the diaphragm curve away. If you see the diaphragm curve away from the chest wall, it means one of two things. You'll see it in one of two scenarios. It means you are either at the pericardial diaphragmatic window or you have pathology, okay? So down here where it's red, that would be where the heart and the diaphragm touch. I will see the diaphragm curve away here because the heart allows the beam to travel through the soft tissues and you see the diaphragm curve away. But you only see the diaphragm curve away from the chest wall in a healthy animal where the heart and the diaphragm come together. Everywhere else along this line here, you'll see this vertical edge artifact. So this would be normal. Don't see the diaphragm curving away. If I see the diaphragm curve away from the chest wall anywhere in green, it means I've got pathology present. I should not see anything other than a vertical edge all the way along this line, with the exception unless the heart's touching the diaphragm, okay? So another question in the audience, is it the same thing as a lung point? So it is not. We're going to talk about what the lung point is when we talk about pneumothorax, okay? So we will come back to the lung point. It's not the same as the curtain sign, okay? Good question, but it's not the same as the curtain sign. Curtain sign is normal in all of our healthy animals. The lung point is specific for pneumothorax. So I will come back to that. It's a good question. But we're looking at this vertical edge. That's the curtain sign, present in our normal healthy animals. So it means if you see it curve away, the diaphragm, you're either down here where it's red, that's normal, or you're in the green zone and it means there's pathology, okay? So this is our curtain sign. Those are all normal lines and signs scheme, okay? There's our curtain sign, opening the curtains. Okay, so our summary on our concepts, we'll go a little bit more and then we'll take a short break, give you guys a chance to take a short break. But our summary when it comes to normal findings, we never want to compromise patient safety. So we're always going to scan our patients in the position they're most comfortable. Know your borders, okay? Make sure you're comfortable with your different borders outlined again here in blue, red, pink, and green. Those are our normal borders. Know your normal lines and signs, right? Know your A lines, your B lines. Remember, you cannot assess the lung as being normal or abnormal if you don't see lung sliding. You got to make sure the lung is against the chest wall for you to say whether it's a problem in the lung or not, okay? So remember, you got to see that lung sliding or B lines to confirm that the lung is against the chest wall, and you can now assess them, okay? And when you're assessing the lung, remember, you're going to assess each window, how many B lines are present, is there a problem there, and over the entire hemithorax, not just one window, that's it, that's all. Add everything up, okay? Any questions at this point? There were some good questions that came up. We talked about M mode and we talked about the lung point. We'll cover the lung point in the normal lectures, and I will go back to what the lung point is when we talk pneumothorax. Any questions at this point, team? On normals?
I have a short question.
Yeah, absolutely.
These B lines that you say are naturally found in many patients are more frequently located in ventral positions or areas due to gravity or not?
Yes.
Okay.
So an excellent question. In healthy animals, when we see B lines, where is it we're most likely going to see those B lines? So it's a really good question. And if I look at the schematic here of the dog, where would I see B lines most likely occurring in healthy animals? Absolutely. It tends to be in the more ventral regions and at the periphery of the lung. So I might see them on the ventral regions or sort of along this caudal border. So it's where the lung is very thin. So we'll see them more likely in those spots. Yes, it's less likely that I'll see them dead center in the lung because that's the thick part of the lung that's really well aerated. And often that's because of exactly as the person said, because I might have some gravity dependence with decreased perfusion in those sites. So we get that VQ mismatch more in the gravity dependent regions. Excellent question. All
Okay,
right,
thanks.
you're welcome. If there's no other questions, we'll move into the first of the lung pathologies, and then maybe we'll take a short break at the end of lung pathology number 1. So let's talk about our 4 pathologies. Now we understand what we're looking at. We know everything looks good. What are the 4 pathologies? And again, this is why I love lung ultrasound. This is why I think it's so fascinating. You put a probe on the abdomen, there's a ton of organs in there. The spleen, the liver, the pancreas, the GI tract, the adrenals, lymph nodes. There is so much in the abdomen, it can be confusing. In the chest, you've got lung, so you've got pleural space and lung diseases, and you got the heart. We look at the heart separately, which means we're not looking at pleural space and lung. There's only 4 things we look for. That's why I love pleural space and lung ultrasound. So what can we see when we put the probe on the chest in our patients? As we said, when you put that probe on the chest, you're going to see the subcutaneous tissues and intercostal muscles. So you see this part up here, and then you see air-filled lung, which is an artifact, and rib shadows. But what are the 3 scenarios? We're going to keep this simple. What are the 3 scenarios we can see when we put a probe on the chest, knowing that this is what we will normally see in healthy animals? Well, we can have air-filled lung. So we can put the probe on and we'll have air-filled lung. And we'll show what that looks like in a second. What else could we have directly below the inside lining of the chest in patients when we put a probe on? We could have fluid. So there's our pleural effusion. And in this case, because fluid's a friend of ultrasound, I will see the surface of the lung deep to the fluid. What's the third thing we can commonly encounter? Air, pneumothorax. And in that case, I don't see the lung surface because there is a separation by air, okay? But those are the 3 big things we'll see. Those are really the only big 3 things we'll see. What do those actually look like with ultrasound then? Talking about this. If it's a healthy animal at that probe location, we're going to see lung sliding like you see here to the left, horizontal shimmering, and we may or may not see A-lines, but that's what we're going to see. Lung is against the chest wall. We're going to see lung sliding. Perfect. What about fluid? Well, that's simple. We see the inside lining of the thorax. We see the fluid. Because fluid is a friend of ultrasound, I see the lung
El
surface.
ultrasonido veo la superficie pulmonar. Este paciente, aunque vea la parietal y pleura visceral, no tiene deslizamiento presente. ¿Y por qué? Porque no veo el destello a lo largo de pared torácica, ya que el pulmón que causa este deslizamiento y destello está separada de pared torácica por fluido. Y veo la superficie visceral del pulmón, ya que fluidos son amigos del ultrasonido. Cuando lo reproduzco, que no hay destello a lo largo de pared torácica, pero si veo ambas pleuras, ya que el fluido es presente y veo se hace fusión pleural. ¿Y cómo se ve la cuarta situación? La neumotórax. En esta situación veo que todo es bastante normal. Veo piel subcutánea.
Then I get my rib shadows and I get a soft tissue air interface. So in this situation, the lung is down here somewhere, but I don't see the surface because there's air in between and air is an enemy. So all I see is a normal looking region with an absence of lung sliding. It's that absence of lung sliding that tells me it's a pneumothorax. And we will come back to that again because it can be challenging, okay? So those are the 3 situations. So like we said, you're either going to see lung sliding, the lungs against the chest wall, you're going to see fluid in that space, or you're going to see pneumothorax. All right, what if it's lung that's against the chest wall? We just said if you see lung against the chest wall, you can interpret it for pathology. If you see lung sliding, you can interpret the lung surface. So I see lung sliding here. Excellent. What are the 3 situations I will encounter when I see lung sliding? Well, this one's pretty easy too. If it's lung sliding, you're going to see less than 3 B lines. That means that lung surface is normal at that site. We might see B lines, which tells us there's pathology in the lung when there's too many sites affected, or I have more than 4 B lines at one location, okay? And the last scenario that we'll talk about, lung consolidations. So we're going to talk about B lines and lung consolidations, as well as pleural effusion and pneumothorax, okay? So let's go ahead and start with what I think is the easiest thing to diagnose with lung ultrasound and plus, and that is increased B lines, okay? When do we see and what do we see with increased B lines, and what does that tell us? Okay, let's look at increased B lines. Like we said, this is super simple. More than 3 B lines in a single window is pathologic for decreased aerated lung at that probe location. So I look down here to this video on the left. And I'm just going to put this on the laser mode. So I look down here, there's my pleural line team. Can you all appreciate that there is a lung sliding here and that there are B lines that are moving here? So I look at this here. Again, there's my rib shadow, there's my rib, there's my pleural line. It's a little hard to see the shimmer clearly, but there is some shimmering there. More importantly, I know there's no pneumothorax because I see vertical white lines. And I see vertical white lines that move left and right with respirations. And I see 1, 2, 3, 4. This patient has increased B lines. This patient has pathology in the lung that's decreasing the aeration at the periphery, or it's got something that's causing decreased aeration at the periphery of the lung. Now I look at this one over here to the right. Same situation. I have my subcutaneous tissues, my intercostal muscles. I have the probe turned parallel to the ribs, so I don't see the rib shadows like you see here to the left. I have the probe parallel, but you can all appreciate there are a lot of vertical white lines that are moving with respirations. This patient has less aerated lung at the periphery than this one. Both have decreased aerated lung at the periphery. Okay, so this is transthoracic with the probe perpendicular, transthoracically with the probe parallel. We can also see increased B lines at the subxiphoid site through the abdomen. You put that probe on at the subxiphoid, you come through the chest, you angle towards the caudal lung region, and I can see regions of lung that I couldn't see transthoracically. I come in and I can see the caudal lung through that subxiphoid. So I see the liver here, I see the diaphragm. Now, normally I shouldn't probably see more than 2 or 3 B lines coming off the diaphragm. And in here, I've got way more. Look at all those vertical white lines just peeling off the diaphragm. This patient has decreased aerated lung at the caudal lung that I can see through the subxiphoid. Okay. So now, team, the question I have for you then is, when do we call these abnormal? And we talked about earlier that they look like lightsabers. So my colleague, Dr. Soren, thinks they look like lightsabers. To me, these aren't lightsabers. These are rays of sunshine from the heavens. As I'm walking in the Lake District in the United Kingdom with a buddy of mine, sitting there at sunrise, I was like, wow, look at that sunrise. I was like, holy frick, look at those B lines. They're just radiating down. These to me look like rays of sunshine from the heavens. So if you go scuba diving, you look up through the water, you see all those B lines coming down. You will see them everywhere now. Everywhere you go, you're going to see B lines coming down from the heavens. Okay. So those are our increased B lines. I think they look like rays of sunshine. All right. So what do B lines mean then? If I see increased B lines, yeah, okay, it's abnormal when I see more than 3. But we also need to consider how many sites are affected. Well, the bottom line is I really like ultrasound because if you guys think about an X-ray, you guys see an interstitial alveolar pattern on an X-ray. This is what happens. You put pathology in the lung, you're going to see this interstitial alveolar pattern on an X-ray. If I take an ultrasound probe and put it right here where I see this on an X-ray, I will see this as B lines on an ultrasound. B lines and consolidation. We're going to come back to consolidation. So the nice thing about ultrasound and radiographs, they're telling me the same thing. It's just 2 different modalities to tell me exactly the same thing. If I take an X-ray, what does it look like? Looks like this. Put a probe there, what does it look like? Looks like this. Increased B lines are telling me the same information I would get off a radiograph. It's an interstitial alveolar disease. And the cool thing is, if you know what you're seeing on a radiograph, you know what you're seeing on ultrasound, the differentials are the same. You need the history and the clinical picture. So what do we mean by that? For example, team, if you get a dog that comes in and he's vomiting, all of a sudden it becomes dyspneic after vomiting. And you took an X-ray and you saw that he had interstitial alveolar disease in the cranial ventral region, you would think aspiration pneumonia. If you do if you do ultrasound and you see increased B lines in the cranial ventral region and a dog that's vomiting, you should be thinking the same thing as if you saw an interstitial alveolar pattern on a radiograph, aspiration pneumonia. Okay, so I'm going to give you another one, team. Dog comes in, hit by a car, respiratory distress. You pop a probe on and he's lit up with B lines. Why do you think he's got B lines following a hit by car incident? Just think if you took an x-ray and you saw an interstitial alveolar pattern in a dog following trauma with an x-ray, what would you be thinking? You should be thinking the same thing when you see B-lines after dogs hit by car. So anybody want to type an answer to me? Contusions, absolutely correct, team. This is pulmonary contusions unless proven otherwise. So again, you already know what you're looking at because you're comfortable seeing it on an x-ray. It's the same information. It's just showing up as B lines instead of interstitial alveolar on an x-ray. You already know what you're looking at, okay? So the next thing, we often say wet lung when we see increased B lines. A lot of people say, oh, it's wet lung or dry lung. Most of the time it's wet lung, but it does bother me when people always say wet lung when they see increased B lines. Why is that? Well, like we said, if you put a probe on and you see increased B lines, the vast majority of cases that have increased B lines will have increased B lines because of wet causes, what we call wet B lines. That is increased extravascular lung water, extra water in the lung outside the vascular system. So it's water, it's edema in the lung itself outside the vessels. What are the causes? Hemorrhage, non-cardiogenic pulmonary edema, congestive heart failure, fluid overload, ARDS, acute respiratory distress syndrome, pneumonia, aspiration. By far the most common cause of B lines, the most common cause to get decreased aeration in the lung at the periphery in our cats and dogs is because of wet lung. But are there other things that will decrease the ratio of air at the periphery of the lung? If you took an x-ray and you saw an interstitial alveolar pattern, is it always edema? Is it always fluids in the lung that causes an interstitial alveolar pattern? No. Just like I said, ultrasound's telling us the same thing as x-rays. So it's not always wet lung in an x-ray. It's not always wet lung that causes B lines, okay? Most often it is. This is the most common cause, just like it's the most common cause in x-rays. But just like x-rays can cause an interstitial alveolar pattern because of things other than fluid in the lungs, we can see dry B lines. You will see increased B lines for things that don't put fluid in the lungs. What are those? Increased cells. Put cells in the lung, it decreases the ratio of air. We can see B lines with fibrosis, inflammatory infiltrates, and neoplasia. And this is the kicker. You take a lung and you put pathology into it. You put cells into it, you put fluid into it. You've got decreased ratios of air to tissue because you put pathology in the lung. I don't even have to put pathology in the lung to cause B lines. Decreased ratio of air at the periphery. I can take air out of the lung. No pathology, no fluid, no cells that I'm putting in there. I'm just taking air out of the lung. I will see B lines develop. So I will see B lines without atelectasis. Okay. So I don't even need to have pathology in the lung. I just need to decrease that ratio of air. So this is why it's important. You see increased B lines. You don't take a patient that's got atelectasis because it's been laying on its side for 12 hours and treat it with furosemide. You just put them into sternal, breathe for them a little bit, those B lines disappear. There's no lung pathology. So think about B lines, most common, wet lung, you bet. But don't overlook the other causes or you're going to be treating them incorrectly because there's lots of things that cause increased B lines, just like there's lots of things that cause an interstitial alveolar pattern on an x-ray, okay? Excellent. So that is not wet lung causes, okay? So we got to think about all the things that decrease the ratio of air. Now, let's talk about prognosis and let's talk about the severity of those B lines. Now, this is true. If I look at these patients from left to right, A, B, and C, A has one B line, maybe two. The second one has lots of B lines, but I can still see individual lines. The third one, these B lines are so numerous, I don't see individual moving lines. It's a solid white sheet. A lot of people will miss this as being pathology because they're so used to looking for lines. If the lines get so bad, it becomes white lung. That is really decreased aeration in the lung. So I look at these three and I can tell you that A, B, and C, C has less aerated lung than B, B has less aerated lung at the periphery than A. So as we decrease the ratio of air in the lung, the number of B lines will go up until it goes from no B lines to white lung, okay? So I can tell you it's got decreased aeration at the periphery and that C is worse than A in terms of aerated lung. But I cannot tell you prognosis, okay? It depends on the underlying cause. just like an x-ray. If I showed you an x-ray with interstitial alveolar pattern, and I said, what's the prognosis between these two dogs that have a similar pattern? You can't tell me unless you know the underlying disease. Same situation with ultrasound. I got two cases that come in, team. I got a dog on the right. He comes in for the first time ever with a heart murmur, and you put a probe on, you see these number of B lines like in this clip here or the still image, and he's got underlying heart failure. He's never been treated before. He's never been on medications. This is the first time he comes in. And then I take another patient with exactly the same number of B lines, and instead of being congestive heart failure, never treated before, I tell you that this patient has a fungal disease. He's in ARDS, he's in sepsis, he's on vasopressors, and he's on a mechanical ventilator. Same number of B lines. Which patient has the better prognosis? Which patient would you rather treat with this number of B lines? The patient that's never had congestive heart failure before, never been on medications, coming in for the first time with congestive heart failure? Or would you take the patient on the ventilator that's got ARDS, sepsis, and a fungal disease? Now, I'm a criticalist. I would take the patient on the ventilator. But from a prognosis and a standpoint, then we're going to take this patient on the right. It has a very good prognosis that we can get those B lines under control with furosemide. This patient over here on the left, he's got a less than 5% chance he's ever going to go home. So it depends on the underlying cause, not just the number of B lines, okay? If it's the same patient and we're following him serially over time, then the number of B lines does correlate to prognosis. So for example, we get a dog that comes in with congestive heart failure. He comes in, we put an ultrasound probe on, man, he's just all white. He's got white lung. He's got a ton of B lines in his lungs. I start him on furosemide, and he gets from white lung to a striped pattern to only one B line. The prognosis in that patient is excellent because he went from fluid in the lungs to almost no fluids. I know he's responding to furosemide. So the prognosis in the same patient in response to therapy does hold true. So you got to think about the disease, and then you can follow it serially within the same patient, and we can see that will influence prognosis, okay? Just keep in mind that lung ultrasound is a surface imaging modality. Now, this is interesting. If it's only retelling me that there's pathology at the surface, I can't see anything below the lung surface. I could potentially miss pathology in my patients if that pathology doesn't reach the lung surface. This is true. However, if you look at the human literature and you say, in people, if you get diseases that will cause B lines or consolidations, 95% of the time, that pathology reaches the lung surface. We don't know what it is in veterinary medicine, but it's probably similar. So if you get a patient that's going to develop B lines or consolidation because of lung pathology, 95% of the time, it will reach the lung surface. So there's a good chance we're going to find it with lung ultrasound. So for example, we look at this x-ray on the left. I can see that this patient has interstitial alveolar disease. I know that 95% of the time, if it causes interstitial alveolar disease, it reaches the lung surface. What am I going to see? Increased B lines. Perfect. What about this cat, though, on the right here? This is a cat that comes in and he has a mass in the lungs. Does this mass reach the lung surface? Does it reach the chest wall? No. There's a little bit of air between this mass and the chest wall. Air is an enemy of ultrasound. If I put a probe right at this location on this cat, I am not going to see it. If it doesn't reach the lung surface, you will not see it. 95% of pathology reaches the lung surface, but there are pathologies like this mass in the cat that you will not see, okay? Lung ultrasound is a surface imaging technique. We may miss pathology if it doesn't reach the lung surface, okay? All right, so we're going to talk about one more quick thing before we take a short break and then move into the other pathologies. We're going to talk about the artifacts, the things that exist just to screw you up, okay? Now, if I showed this here outlined in red, you put a probe on here, this is white. This is vertical. This comes from the pleural line. Is this a B line? Yes or no, and why? Well, remember, if it's a B line, there were 5 specific criteria. What's the one criteria I use the most to tell me if it's truly a B line or not? Does it move with the breathing and the lung sliding? To me, that one's key. As I said, if it's a B line, it's coming off the lung surface and it's moving with the lung as the patient breathes. If I look at this clip, can you all see the lung sliding where my little red dot is? Can you see that to and fro horizontal movement right there? Yes, hopefully you can all see that. Does this move in sync with this? No. It moves with the rib surface. It moves with the contraction of the intercostal muscles. This originates at the parietal surface and above. So it moves to the chest wall, not the lung. Therefore, it's not a B-line because all B-lines have to originate at lung surface and move with lung sliding. This doesn't. This is an artifact. This is a Z or a Z line. Call it whatever you like. Something with a Z or a Z in it. What's the significance of that? You will see it in all your healthy dogs. You'll see it in all your healthy cats. And they have zero. Z for zero. They have zero significance, okay? So Z lines are there just to screw you up and make you think they're B lines, okay? So they have no clinical significance. If I see a vertical white line when I'm scanning my patients because I'm moving the probe, I freeze. I hold the probe perfectly still, and then I say, that white line, does it move with the respirations, yes or no? If the answer is no, it's not a B line. B lines have to move horizontally as the patient breathes, okay? And in sync with lung sliding. All right, let's look at one more before we take a short break, team. This is the last clip before we talk about summary. So if I showed you this one here, team, how many of you would say this patient has B lines? Now I look at it and think, yeah, looks like he's got some vertical white lines. Are those B lines, team? And the answer is no. What? They're moving, they're going back and forth. Why are those not B lines? The reason they're not B lines, this is the stomach wall. This is gas in the stomach. You are actually at the curtain sign right here. This is lung here to the left of the rib. You're seeing right over here. That's lung right there. You're coming back, you hit the curtain sign. This is the stomach wall. You can see the actual layering of the stomach wall. Once you hit the curtain sign, the ultrasound beam goes to the soft tissues of the abdomen until it encounters an enemy. And in this case, the only soft tissue before it gets to an enemy, because you're on the left side at the area of the stomach, is the stomach wall. Then you get gas in the stomach. That can look like B lines. And this is why we always say, start over lung and slide caudal. If you start over lung and you slide caudal, you'll see you're at the pleural line, curtain sign. So you'll see this sudden shift. You know you're on the left. That's lung, stomach wall, okay? On the right side, it's easy because you come back off lung, you hit the liver at the curtain sign, you get a nice long soft tissue interface. But on the left side, that soft tissue interface that makes up that curtain sign might only be the stomach wall. If you guessed and put the probe over the left side and you're at the curtain sign thinking you're on lung, you might get this. And I've seen a lot of people wonder why the patient's breathing well despite having what they think is B lines. It's because it's in the abdomen, not the chest, okay? So like I said, we always recommend you start over lung and then you slide back caudally till you get to the curtain sign. So that if you happen to be on that curtain sign, you'll see the transition from a pleural line to the stomach wall or gas-filled intestine, and not make the mistake if you start back here and accidentally see that thinking it's lung pathology. So we don't guess, we always use our borders and we slide back to the curtain sign, okay? So in summary, just before we take a short break, occasional B lines, like we said, are normal. Less than 3 per site at only 1 to 2 sites on that chest wall. Perfect, that's normal. Increased B lines indicates decreased air at the lung periphery. So I look at this image over here to the right. There's my rib shadow. There's my rib. There's my pleural line. Look at all those lovely moving B lines. This is in the lung. It's not over the abdomen. These are B lines, okay? More than 3 per site, or if you have more than 2 sites affected on a hemithorax, you should be worried about pathology. You need to think about the history and clinical findings, okay? It doesn't quite follow the same pattern as radiographs. Congestive heart failure on a radiograph in a dog is usually starting perihilar. On ultrasound, it's more sensitive than radiographs. It's diffuse and bilateral. So heart failure, congestive heart failure on ultrasound, diffuse bilateral B lines, okay? Aspiration pneumonia does follow what happens on radiographs, and on ultrasound, it tends to be cranial and ventral. It can also, just like with pulmonary contusions on radiographs, it can be unilateral. So think about, make sure you scan both sides of the chest. Don't confuse Z lines for B lines, okay? Stop and assess if they move with lung sliding. Another nice example down here. This is with the probe parallel to the ribs. There's my lung right here, and then I'm getting a bit of the cardiac notch in the heart right here. But this is the lung here. Do I have vertical white lines moving back and forth with respirations? Yes, right here. There's probably about 4 here. So I'm worried there's some pathology in the lung. These here, what's this right here? These are A lines. You can see they don't move with the B lines. They don't move with the lung sliding. So this is just a really nice example where you've got some Z lines or Z lines as well as B lines in the same window, okay? All right, so at that point, we are going to move forward and we're going to talk about other lung pathologies next. We have gone for almost an hour and 20 minutes with the lecture. So we're going to finish up with some of the other pathologies. Anybody got any questions? Because I am going to give you guys a short break. So we'll take maybe, what are we at now? Time, we're at 11:25. So I think we're supposed to give you a 10-minute break just to keep you guys all sane. I could keep going, but I was told I need to give you a break. So.
Dr. Soren, just don't leave this chat, this room, because we're going to stay here. We're not going to change the rooms because the pause, la pausa, it's in, it's right now. It's on live.
Good.
Okay.
So are we
Si
okay to
alguien
take a
tiene
break or
alguna,
should I keep going?
you
Are we
can
taking-
put your camera down for 10 minutes and then come back if you want.
Oh,
Or if
okay.
you want to stay, it's okay.
I will be back in 5 minutes.
Perfect. We're
But
waiting for you.
I will, since it's still morning here, I'll grab a coffee.
Perfecto. Muchas gracias por mientras vamos a hacer esta pequeña pausa, mientras el doctor Soren toma 5 minutos de descanso. Va a ir a hacer un café para poder seguir con la segunda parte de su charla. Ah, doctor Soren, no le pedí que por favor dejara de compartir pantalla. A ver, vamos a, porque necesito la pantalla y él se fue. Ah, perfecto. Ahora sí. Por favor, Jordi, ahí está. Estaba buscando su nombre. Él es el sponsor Ultramed y nos va a dar esta pequeña pausa para nosotros en esta primera jornada del 10º Congreso de Imagenología Veterinaria. Jordi, por favor, el escenario es todo suyo.
Vale, muchas gracias. Primero que todo, agradecer a la directiva y al comité de organización del Congreso por permitirnos tener esta pausa para mostrarles algo de la tecnología que nosotros comercializamos y llevamos a cada uno de ustedes. Nosotros somos los representantes de la empresa Vino de China de ecografía y les voy a mostrar algunos modelos que son los que en general se ocupan en veterinaria, ¿no? El primero es el modelo D2VET, que es el modelo básico, permite conectar un par de transductores simultáneamente, nos permite hacer, por supuesto, eco abdominal, ecocardio, ecopulmonar, como la que nos estaba enseñando el doctor Boysen. Tiene una pantalla de 15 pulgadas, ¿verdad? Un ángulo ajustable, soportes para los transductores y, como les decía, nos permite conectar 2 transductores simultáneamente. La batería dura alrededor de 1 hora y media y soporta cardiología. Después tenemos la gama de ultra portátiles, que son tipo laptop, que es el Vino 5, Vino 6 y Vino 8, que son bien conocidos y hay varios colegas suyos que trabajan con estos equipos hoy en día. El Vino 5 se especializa en ecoabdominal, el 6 permite agregar cardiología un poquito más avanzada, y el Vino 8 nos permite incluso hacer ecocardiografía transesofágica. Tiene una pantalla de 15 pulgadas, pesa alrededor de 3,5 kilos, ¿verdad? Un touchscreen de 8 pulgadas, podemos ponerlo en un carrito, multiplicar la cantidad de transductores simultáneos a 3, y tiene un disco duro de estado sólido que nos permite un trabajo bastante rápido y bastante eficiente. Nos permite también poder hacer el informe en el mismo equipo. Pasamos a la gama de estacionarios. Tenemos 3 modelos de estacionario, el de 300, 550 y el 650, que tienen diferentes características principalmente físicas, ¿no? Tamaños de pantallas, el 650 tiene una pantalla de 23 pulgadas, un touchscreen de 13, nos permite conectar simultáneamente 5 sondas, y nos permite además hacer ecocardiografía, strain y también eco de contraste. Aquí tenemos algunos ejemplos de imágenes, ¿verdad? Cardiológicas, modo color, modo M-color, Doppler color, ¿verdad? Tanto de abdomen como de ecocardio. Vino es la única empresa de ecografía que tiene un sistema de monitoreo remoto de los equipos. Podemos hacerle mantenimiento remoto a los equipos, ¿verdad? A través de internet. O sea, cada vez que si ustedes tienen algún problema en, por ejemplo, el preseteo de la imagen o algún problema técnico, nosotros podemos conectarnos al equipo, tomar control del mismo y revisar en conjunto tanto el registro de errores como poder configurar con ustedes algún preseteo que sea más adecuado a lo que ustedes están esperando, ¿verdad? Podemos tener mejor resolución, ¿verdad? Desde nuestro centro de servicio técnico. Tenemos la posibilidad, como les decía, de conectarnos remoto y poder ver el equipo de forma remota, lo que acorta los tiempos de atención y hace mucho más eficiente el trabajo de todos. Aparte de Vino, nosotros trabajamos también con una empresa de tomografía portátil que se llama Neurológica, que está basada en Estados Unidos y es subsidiaria de la empresa Samsung. Neurológica tiene 3 modelos de tomógrafos portátiles. ¿Por qué portátiles? Porque son capaces de rodar por las distintas salas y el equipo es el que se mueve para hacer el escaneo sobre una plataforma donde está el paciente, que puede ser fija o rodable. Además, el equipo nos permite enchufarlo a la corriente normal, porque tiene un módulo de baterías bastante potente, que nos da autonomía de alrededor de 12 horas de trabajo. Existen 3 modelos distintos. Existe el BedTom 8, que es de 8 cortes, con slices de 1.25, y un gantry de 32 centímetros, y nos permite hacer escaneos helicoidales, axiales y dinámicos, incluso con perfusión. El modelo de 16 cortes se llama BedTom 16, tiene un gantry un poquito más grande, de 40, y nos permite hacer cortes de 0.625 milímetros. La gracia del BedTom es que en un futuro muy cercano, de hecho las unidades de uso humano ya se están upgradeando, van a pasar a ocupar detectores de conteo de fotones, que es la última tecnología de tomografía que existe. También es portátil, también es rodable y permite ser utilizado en distintas salas. Y el BedTom 32, que es un equipo de cuerpo completo, que se llama, con un gantry de 85 centímetros de diámetro y de 32 cortes, también con escaneo helicoidal axial dinámico y perfusión. Podemos hacer todo tipo de estudios, ya sea con o sin contraste, además de reconstrucciones 3D, etc. Son todos tomógrafos de detectores de estados sólidos reales, no de CBCT, que son estos arcos C que rotan en torno al tubo. Les voy a mostrar un pequeño video donde podemos ver un rinoceronte siendo escaneado en el zoológico de Brookfield, en Chicago, ¿no? Ellos tenían el problema de que no tenían forma de poder llevar, por supuesto, un rinoceronte que necesitaban hacerle un escaneo nasal, porque tenía algún tipo de deformación. No lo podían transportar fuera del hospital, pesa alrededor de 700 kilos, y entonces los veterinarios pidieron que Neurológica les prestara el tomógrafo para poder hacer el escaneo de este rinoceronte, ¿no? Entre 40 personas lo tuvieron que mover, y esto es una experiencia en animales de gran escala con un tomógrafo portátil, ¿no? Les pedimos que nos sigan en nuestras redes sociales, @ultramed_vet. Vamos a tener sorpresas, mañana tenemos otra presentación con otros productos y vamos a presentarles algunas ofertas para los asistentes a este congreso.
Muchas gracias, Jordi. Una
Muchas gracias a
consulta
ustedes por su
estaban
tiempo.
realizando. ¿Los 3 modelos son de corriente monofásica?
Exactamente, son monofásicos, funcionan con 220 volts y 16 amperes.
¿Y las baterías cuántos años duran aproximadamente?
A ver, las baterías están vigentes más o menos 5 años.
Perfecto.
Y te permite un trabajo continuo de hasta 12 horas en el caso de corte eléctrico, por ejemplo. En Chile hay dos de estos equipos, están obviamente en medicina humana, pero hay dos de estos equipos en hospitales públicos. Que hay uno de hecho que hace bastante cirugía de espina y de cerebro.
Ahí espero que hayamos contestado la pregunta de esta persona que estaba ahí interesada en saber acerca más de estos productos. Así que sigan por favor a Ultramed en @ultramed_vet para más información y puedan saber las novedades que tiene. Muchas gracias, Jordi. Por favor, para darle nuevamente el paso al doctor Boysen.
Muchas gracias.
Déjeme confirmar si está el intérprete para, disponible, listo para conectarnos nuevamente. Give me just 1 second, Dr. Boysen, to... Ahí está, ahí me hizo el ok. Perfecto, entonces podemos continuar. We can continue with your lecture, Dr. Boysen.
All right, perfect. I will just put the mode back in. Excellent. Thank you very much. So really interesting. I've never seen a rhinoceros CT'd before. That was quite exciting to see a rhinoceros get a CT scan. Very cool. Lots of things we can do with ultrasound as well. So we're going to move on with our next pathology when it comes to pleural space and lung ultrasound. And we are going to talk about pleural effusion. Now, if I ask the question, and I usually do this when I'm lecturing in person, I usually ask how many people are comfortable identifying and diagnosing pleural effusion with ultrasound. Almost everybody raises their hand. Everybody feels comfortable looking for pleural effusion, which is interesting because if you look at the literature and you want to actually see how good we are at diagnosing pleural effusion, we are not as good as we think we are. If you get a cat that comes in like this one on the left, and it's full of pleural effusion, we're all going to be able to identify that. But if you look at the literature and you say, how often do we miss pleural effusion? You can see that a study that was performed by Dr. Walters in 2018, looking at TFAS performed by emergency critical care residents compared to CT in dogs and cats suffering trauma, they missed almost half of the cases. So we did not do as well as we thought when we're doing our pleural effusion. And same thing, if you look at a recent study that was published by the crew out of the RBC, Dr. Cole and her team in the United Kingdom, you can see they missed a third using a different format. So we're not as good as we think we are at identifying pleural effusion. We will miss a third to a half. Now, in those cases, if you look at the actual literature, these cases that were missed didn't have large amounts of fluid that were causing respiratory stress, but they missed smaller amounts of fluids that would not cause respiratory distress. And these are the ones that, although they're not causing respiratory distress, might help us with a diagnosis. So maybe they have a neoplasia that we could have diagnosed if we'd found the small amount of fluid that wasn't causing respiratory distress. So why is it that we miss those cases with pleural effusion? And I think this has to do with how point of care ultrasound has evolved when it comes to looking for pleural space pathology. If we look at the original study, the landmark study that was published by Dr. Alessandro in 2008, we look at that TFAS site, those patients were in right lateral recumbency when they did that original study back in 2008. They scanned 145 patients, the vast majority in right lateral recumbency. If my patient's in right lateral recumbency, where's that fluid going to accumulate? It's at the gravity-dependent site. So it's where the patient, if he's lying on his side, that fluid's going to come in and it's going to accumulate on the gravity-dependent chest. And if I come in underneath the patient and put the probe at the heart, which is where it recommends doing that in a TFAS protocol, then I'm going to see that pleural effusion. And I'm going to see the pericardial effusion like you see in this still image down here. So if I come in underneath the patient, great spot to look for fluid when they're lateral coming underneath. Unfortunately, most of the patients we scan for pleural effusion are scanned in sternal or standing, not lateral, because we don't want to scan patients with respiratory distress in lateral. We scan them in sternal or standing. And where is that fluid going to accumulate when they're in sternal or standing? My patient is sternal or standing. that fluid is not going to accumulate over the heart. If it's a large amount of fluid, yes, I will see it there. But if my patient is sternal or standing, I should not be looking only at the heart. I need to think about where the fluid's going to accumulate. And it's going to actually fall to gravity-dependent regions. So if I'm looking at the original TFAS site, I might miss that fluid if it's a small amount. I need to get off the heart and think about patient positioning and think about where that pathology is going to accumulate and assess those sites. And this is where borders become very important, because you can see down here, it's going to accumulate at that caudal border between the sternal border and that caudal curtain sign area at that PD window. So I need to think about that ventral pleural border and that caudal border to make sure I assess this site in this patient that's standing for small amounts of fluid. Borders are important, and you have to think about what pathology am I looking for? Where is it going to accumulate based on patient positioning? And then change how you look for it based on patient positioning. In right lateral, come into the pericardial site on the underside of the patient, like the original study. Any standing patient, think about where that fluid goes, adjust your protocols to maximize success. So we do this in all the labs. Whenever we do hands-on scanning wet labs, we do a lot of ultrasound labs with our attendees. And one of the things we'll do is we'll get you to find that pericardiodiaphragmatic window. We'll get you to find this site here using your borders. So how do we do that? Well, here we are over our patient. We've started over lung. We slide back to the curtain sign. So again, that curtain sign is very, very important. We slide back to the curtain sign. Once we get to the curtain sign, we can follow that ventrally until the heart and the diaphragm come together in the same window. So here's just a quick video showing you what it looks like. It's hard to do on a video. It's nicer to get in hand or in-person wet labs. So maybe one day I'll come down to Chile, watch some football with you guys down there, and we can do a hands-on scanning lab. But here's the window. See the vertical edge of the curtain sign. It's vertical all the way down until the heart and diaphragm come together right there. So that is the heart and the diaphragm coming together right here at that pericardiodiaphragmatic window. Here's the heart here to the left. There's a little bit of fat between the apex and the heart. And there's where you see the diaphragm curving away from the chest wall. So this schematic is normal. We come back, we find that curtain sign, we drop down along that till the heart and the diaphragm are visible. This is a very nice spot, the PD window, for us to differentiate pleural and pericardial fluid. So again, there's our normal patient on the left. You see the heart, you see the mediastinal triangle, you see that diaphragm curving away, okay? This mediastinal triangle can look like pathology. It's not, it's fat. Don't aspirate it, it's normal, okay? But if I find this spot down here and it's pericardial fluid, it will go around the heart. If it's pleural fluid, it'll actually track up here, separate the diaphragm from the chest wall at the costophrenic recess, and it obliterates, it tends to displace the triangle of fat. So what does it look like with fluid when it's pleural? What does pleural effusion look like here? This is what it looks like. So we see fluid tracking along the diaphragm, filling this costophrenic recess right here. So you see the chest wall, you see the diaphragm curving away from the chest wall, which we shouldn't do if you're a little bit away from the heart, and the fluid fills this costophrenic recess right here, okay? That's pleural effusion. Looks really classic, okay? Pericardial effusion, on the other hand, curves away from the diaphragm and around the heart. So here I am, I can still see that mediastinal triangle right here. I see the diaphragm curving away a little bit here because of that fat pad, but where does the fluid go? It does not replace the fat. It does not fill the costophrenic recess. It curves away from the diaphragm and around the heart. So this pericardiodiaphragmatic window is a great spot for us to differentiate pleural from pericardial effusion, okay? So here's a nice example of a case that comes in, and we're looking at this guy. This is the heart. We're just sitting over the chest. I can see the left ventricle, the right ventricle. And the big question I have for everybody that's watching here, is this pericardial or pleural effusion surrounding the heart? Is it mostly pleural or is it mostly pericardial that's sitting around the heart? So I am over the heart here. You would need to move around and assess the patient. But if I'm struggling and I'm thinking, that looks, maybe that's pericardial, but is it truly pericardial or pleural? So I'm not 100% sure. What should I do? Slide back to put the heart and the diaphragm in the same window. And if it's pleural, it tracks the diaphragm. If it's pericardial, it goes away from the diaphragm. So if I do that in this guy here, you can see it looks like it could potentially be pericardial in this image, but in reality, as soon as I slide back, that's pleural. I can see the lung there sliding into the costophrenic recess. I slide a little ventral, boom. Now I have this anechoic fluid filling the costophrenic recess. This patient is predominantly pleural effusion. Here I am over lung, slide down, the PD window right there. I slid down along the lung, along that caudal border, and I see that pleural effusion. Okay. This case here, I can actually see a bit of lung right there, which tells me it's also more likely pleural because you shouldn't have lung in your pericardial space. But again, it's not hard to miss it. Come back here, really easy to diagnose and tell the difference between the pleural and pericardial effusion when you're at that pericardial diaphragmatic window. Okay. So what else can I look at? Smaller quantities of fluid. As we said, if it's a large amount of fluid, you're going to pick it up anywhere in the ventral third. But what if it's a small amount of fluid? It tends to get trapped ventrally along the sternal muscles. And that's hard to pick up with lung ultrasound sometimes. So what's the easiest way for us to do that? We turn the probe parallel to the ribs and then scan ventrally to the sternal muscles. So we always turn the probe parallel to the ribs and come down ventrally. Why does that work? Well, let's look at this CT here to the left. Here's a nice CT image. I got the lung here, I've got the heart, and if I've got a lot of fluid causing the patient to be in respiratory distress, then yes, I put that probe anywhere in the lower third of the thorax, I will see that fluid with the probe perpendicular, for example, to the ribs. Perfect. But if I have a small amount of fluid trapped between the sternal muscles and the lung, I'm going to likely miss that if I have the probe perpendicular to the ribs and I'm staying at the heart or the costochondral junctions. Even if I fan down, I will not see that fluid because I hit air-filled lung. I cannot see this fluid if I stay at the heart or the costophrenic recess with the probe perpendicular. What's the easiest way for me to pick up that small amount of fluid? Turn the probe parallel to the ribs. If I turn the probe parallel to the ribs, I am slicing along the chest wall and including the site where the chest wall transitions to the sternal muscles. And this right here, where the chest wall transitions to sternal muscles, is a beautiful spot to pick up fluid. So here's that chest wall lined in blue, transitioning to the sternal muscles. Here is the chest wall transitioning right here to the sternal muscles. Chest wall, sternal muscles. There's the blue outline. Chest wall, sternal muscles. And right now, I can see fluid between the sternal muscles and the lung and the mediastinal structures. So this here is pleural effusion. Really nice way. Again, patient's probably not dyspneic, but if I find the fluid, I can tap it. Maybe it's going to be diagnostic. We sometimes pick up neoplasia that we otherwise would have missed. So here's a nice example in a cat. We got the probe parallel. I don't see fluid. Turn it, boom, there's the fluid. So once again, here I am, perpendicular to the ribs, no fluid, turn parallel, fluid becomes visible. We didn't do anything else in this cat except go from perpendicular to parallel. And when that probe is perpendicular, there's the rib, no fluid visible. Turn it parallel, sternal muscles, fluid becomes visible. You have a higher probability, we've done the research to show this, of finding that fluid if you turn the probe parallel and come ventral. So if I suspect fluid might be there and I don't see it perpendicular, I always turn parallel and slide ventral, okay? That picks up that fluid for me. All right, so team, I have a question for you guys. We'll see if you're still paying attention after the break. So, my friends, I have a patient here on the left in this ultrasound clip. You guys tell me, do I have at the parietal lining lung sliding? Is there a glide sign in this patient? Yes or no? I'll wait for somebody to answer. No. Excellent. And the answer is no. Why? Because remember, if you have lung sliding, it means the lung has to be in contact with the chest wall, and that lung slide or shimmer occurs along the parietal surface. I see the lung here. This is the lung surface here. This is the parietal surface, chest wall. It's separated by fluid. And therefore, because the lung's separated, I don't see shimmer along this line. So in this case here, I see the lung. in this case, fluid is a friend of ultrasound. Therefore, I can see the lung, I see both surfaces, but no lung sliding or shimmering because they're separated. And if you had trouble seeing that and you're like, man, I don't know if I would have called that fluid, you can simply turn the probe parallel. And look how easy it is to see fluid when the probe is parallel and we slide ventral, okay? There we go, nice lung sliding, nice evidence of pleural effusion where we lose that lung sliding because the pleura are not in contact. The other place that we're going to look for pleural effusion, we got one more spot that we should always think about checking if we want to rule it out with confidence. Don't forget the subxiphoid site. Again, we can put the probe on at the subxiphoid angle through the liver, and it allows us to see the caudal pleural region. And you can see here, this is the cat, we got the liver, we got falciform fat, there's the diaphragm. Look at all that pleural effusion extending beyond the diaphragm. And again, nice spot to differentiate pleural from pericardial effusion. Pleural effusion tracks along the diaphragm. Pericardial effusion surrounds the heart and moves away from the diaphragm. So again, we've got a nice way to differentiate pleural on the left from pericardial on the right if we come in at the subxiphoid. Really nice place to do that. So that's our summary. It was pretty quick on the difference and how we identified pleural effusion. So in summary, again, we have okay ability to pick up pleural effusion based on the studies looking at TFAS compared to CT. However, we can probably improve that ability if we think about patient positioning and where fluid accumulates. Patients in lateral use the pericardial site on the underside of the patient. If the patient's sternal or standing, as we scan most of our patients now with respiratory distress, think about getting to that pericardial diaphragmatic window to help us differentiate pericardial from pleural fluid. And if we really want to rule out fluid that's ventrally along that sternal muscle where it accumulates, turn the probe parallel. Don't forget to also include that subxiphoid site. And if you're scanning the subxiphoid site, make sure you fan the probe to catch the gutters on either side, and you rock the probe to look for small amounts of fluid, okay? So just keep that in mind as well. All right, so that's pleural effusion covered. Let's talk about arguably the most difficult thing that we can diagnose with lung ultrasound, and that is pneumothorax. Pneumothorax can definitely be challenging to identify. So how good are we identifying pneumothorax then in our veterinary patients? Again, we come back to that original study by Dr. Alessandro. This is that landmark study, 145 dogs suffering from trauma, positioned in right lateral recumbency. So most of these dogs were scanned in right lateral recumbency. And compared to radiographs, they didn't have CT in these dogs at this time. They compared ultrasound to radiographs. They got 25 out of 32 dogs correctly diagnosed with pneumothorax. They had 7 false positives and 7 false negatives. Interestingly, if you look at this paper and say, how good are you if you're an expert versus a intermediate ultrasonographer at identifying pneumothorax, you can see that if you are an expert, Dr. Alessandro, really high sensitivity at picking up the pneumothorax, 95%. He had a 95% chance and correctly identified it in most dogs. However, if you look at more novice, less experienced ultrasonographers, the other authors in this paper, they had a less than 50% chance of getting that pneumothorax. So what does that tell me? Experience makes a big difference, okay? Now, what about compared to CT? To truly validate that we can identify pneumothorax, we should compare it to CT. And you see here, small numbers, but they did run a study on VetBlue out of the United Kingdom, Dr. Cole and their crew, 33% accuracy. They missed more cases of pneumothorax than they detected with ultrasound. And if we look at the Walter study, which compared TFAS to CT with EC residents, emergency critical care residents, did the study. How good was TFAS at identifying pneumothorax compared to CT? It had a negative correlation. They actually had a suspicion of pneumothorax, put a probe on, changed their mind, and got it wrong. Ultrasound was a negative correlation compared to CT. Again, small number of cases, but you can see then that you have mixed results on the ability of ultrasound to pick up a pneumothorax. So it is definitely the toughest thing to do. However, once again, if we break this down and we think about what is it that affects our ability to find pneumothorax. Let's look at this, team. We're going to scan most of our patients in a sternal or standing position, not lateral recumbency. And where does air accumulate in a patient in lateral versus sternal or standing? So in this sternal patient here, where is that air going to accumulate? It's going to go to the most gravity independent site, opposite of fluid. Fluid's down here along the sternal border. Air is going to go up to the dorsal border, and it's going to go caudal dorsal. So that air is going to accumulate back here where the red circle is. That's where the air will most likely accumulate. That's different than the widest point of the chest when it's in lateral, okay? So think about your pathology. Where's it going to go? Let's assess the site it's most likely to accumulate. How do we get to that site? We use our borders. We use the caudal border and then follow it up till we get to the dorsal border. And now we know we're at the most sensitive spot, okay? And the nice thing is, if I look for a lung sliding at this most caudal dorsal site, and I have lung sliding here, that means the lungs against the chest wall at the most caudal dorsal site. That means there's no pneumothorax at the most caudal dorsal site. Therefore, if I have a standing patient and I get lung sliding here and there's no pneumothorax here, I don't need to look for pneumothorax elsewhere on this side of the chest. I don't need to look for lung sliding elsewhere on this side of the chest, because if I have lung sliding here and no pneumothorax at the most sensitive spot, very unlikely I'm going to have air trapped down here between the lung and the chest wall. So if I rule it out here, I can now look for with confidence and not have to look for lung sliding anywhere else. I can look for lung pathology. I look for B-lines, consolidation, and pleural effusion, but I don't have to look for pneumothorax anywhere else on this side of the chest if I have lung sliding here. Check the other side of the chest for pneumothorax, but I don't need to look elsewhere on this side if I have lung sliding at the most sensitive spot, okay? That's different than a patient in lateral. In lateral recumbency, this patient came in hit by car, had some pelvic fractures, so we couldn't put him into sternal. He was scanned in lateral. We picked the widest point of the chest. The widest point of the chest is not the same location as the most caudal dorsal site. So when they're in lateral, you're going to scan more in the mid-thoracic region, the widest point of the chest. Go to the spot the air is most likely to accumulate, okay? And I will tell you that if your patient is sternal or standing and you're used to going after a chest tube site and your chest tube site is 2/3 the way up the thorax, you are going to miss pneumothorax in the dorsal third. All the residents that I train, that I test at the Cornell boot camp, a lot of them will put the probe where they put a chest tube. And I've created pneumothorax in a cadaver, and they are below the area of the pneumothorax, okay? So just think about, where does air go? What am I looking for? My patient sternal or standing, got to get to this site up here. You can put the probe here and assess it, but if you have lung sliding here, you should go dorsal to make sure that you still have it at the most sensitive spot, okay? So a lot of people miss pneumothorax because they start too low on the chest. They see lung sliding down here and they're below the pneumothorax, okay? You can use your borders to get to this spot with confidence. All right, now let's talk about criteria more specifically. What do we do to tell us we do or do not have a pneumothorax? This is simple. We're going to keep it, again, easy as we can, simple as possible. There are 2 criteria that rule out pneumothorax at that probe location, okay? 2 criteria that rule out pneumothorax at the site you have the probe. We already covered it, so I'll ask you guys, tell me what rules out pneumothorax at that probe location. What would you see when you put a probe on the chest that rules out pneumothorax where you have the probe? You guys know this, so I'll wait for somebody to tell me. Lung sliding, absolutely. So lung sliding means you don't have a pneumothorax, absence of lung sliding or glide sign, suspect pneumothorax. What else would rule it out? What else would tell you there's no pneumothorax at the site you put the probe? So one thing is lung sliding.
B-lines.
And B-lines, exactly. See, you already know how to rule out pneumothorax where you put the probe. If you see lung sliding, rules out pneumothorax where you put that probe, provided it is a complete lung slide. Come back to that. And if you see B-lines, then you rule it out at that probe location, okay? So lung sliding, if you see it with confidence across the entire image, It tells you the lungs there where your probe is. It is 95% sensitive and 100% accurate at ruling out pneumothorax. The problem is some healthy animals, it's just difficult to see lung sliding, even though the lung is against the chest wall. If you look at the literature, it's hard in humans and our veterinary patients to identify lung sliding, even in a healthy animal in some cases, despite the lung being in contact with the chest wall. So if you see it, it rules it out. If you don't see it, you should suspect pneumothorax, but sometimes it's hard to see. And how do your patients breathe that have lung pathology? When we look for lung sliding in a healthy animal, it's a nice long lung slide. It's about 3 or 4 centimeters. We get to see that lung slide in a healthy animal. In a patient that's suffering from respiratory disease, including pneumothorax, they're not breathing like this. They're breathing like this. Now you've got about 2 millimeters to look for lung sliding because they're not taking nice deep breaths. They're doing really shallow breathing. That's hard to see lung sliding. So it's hard to see it sometimes, even if the lung's in contact with the chest wall, okay? So let's do a quick quiz, team. You can answer this one in the chat box again. So this patient here, where we have this probe, do you see lung sliding in this ultrasound clip? Do you see a nice horizontal shimmer? And the answer is yes. Good job, team. So at this probe location, because I see lung sliding, do you have a pneumothorax at the site this probe is located? Yes or no? No. Perfect. So we do not have pneumothorax here because I see lung sliding throughout the entire pleural surface. Awesome. Next question. If I have lung sliding, can I assess the lung here? And is it normal or abnormal? Is it dry or is it abnormal? Can I assess it? Yes or no? So we'll ask that question again. Can I assess the lung here as normal or abnormal? Yes or no? The answer is yes. Why can I assess it here? Because I see lung sliding. The lung sliding tells me the lung's against the chest wall. And therefore, I can look for B lines or consolidation. I don't see B lines or consolidation, which means at the lung surface, at this probe location, this looks okay to me, okay? But I can't tell you it's normal or abnormal till I see that lung sliding. I see lung sliding, lungs up against the chest wall, it looks normal to me, okay? Excellent, good job, team. That lung sliding tells us there's no pneumothorax at this probe location. Brilliant. Now, what about this one here? Do I have obvious lung sliding in this patient? Yes or no? This is a tough one, eh? I agree. I cannot see an obvious horizontal shimmer here. There's my rib and rib shadow. Rib and rib shadow. There's my pleural line. Man, that's a tough call. I cannot see nice lung sliding here. I will tell you, this is a normal dog. This is a healthy dog. I just can't see the lung sliding nicely in this dog. There are some tricks that make it easier to see lung sliding. I can decrease the depth. I can decrease the gain. I can fan the probe so the beams don't come back to the ultrasound probe, makes it grainier, or I can put one rib in the middle of the image. Those things usually make lung sliding easier. And if we have a lab someday together, I'll show you how to make the lung sliding easier to see. But regardless, sometimes it's really hard to see lung sliding. If you can't see lung sliding, you should suspect pneumothorax. If the history fits, it's a hit by car, patient's trying to die, you should tap him. If the patient's stable enough, we can go looking for things that rule in pneumothorax. So we'll talk about those in a second, okay? So let's just cap this up again. On this patient here, there's my pleural line. Do you see a horizontal back and forth shimmering here? And the answer to that one is, do we have lung sliding here? Yes. C, exactly. I'm getting my Spanish translation in. All right, so that one there. So if I see that lung sliding, rules out pneumothorax. Nice. How about this patient? Pneumothorax, yes or no? does this patient at this probe location have a pneumothorax? And we got to know. Why did we say that? We didn't even really need to look for the lung sliding. I see a B line. See that B line? B lines rule out pneumothorax. Good job, team. Well done. Excellent. B lines mean no pneumothorax at that probe location. Now here's a real patient that comes in with respiratory distress. There you go. Now you guys tell me. There's my rib shadow. There's my rib. There's my pleural line. Subcutaneous tissues, intercostal muscle. There's my pleural line. Does this patient have a pneumothorax? Let's start with a simple question. Do you see obvious horizontal lung sliding or a glide sign here? Yes or no? Or put a question mark if you're not sure. I will wait to see what you guys think. No, and I agree. I can't see obvious lung sliding here. This is a tough one. And I'd say, well, do I have a B line here? No, this is a Z line right here. This is not a B line because it ain't moving back and forth fast enough. This is a Z. And I don't see obvious shimmering. So this patient here does not have lung sliding. Does this patient have a pneumothorax? Yes or no? Should we suspect pneumothorax? Let's put it that way. Because again, we said you can't always see it, especially when they're breathing shallow. So if we don't see lung sliding, we should suspect pneumothorax. So I'm thinking probably. I suspect it. Okay. And next question, is this lung surface dry or abnormal or we can't say? Question mark. We can't say, or is it a yes or no? And in this case here, you guys said you didn't see lung sliding. Therefore, I don't know if there's pneumothorax or not. Therefore, I cannot assess the lung as normal or abnormal here, because if it is pneumothorax and this patient does have a pneumothorax, this is actually a patient with a pneumothorax. That means there's air separating the lung down here that I can't see. Therefore, I can't tell you if that lung is normal or abnormal because I can't see the lung surface. This patient actually does have a pneumothorax, okay? But sometimes you're not sure. You can say, I don't see lung sliding. I don't see a glide sign. I suspect a pneumothorax. But there are things, if your patient's not trying to die, that you can go looking for that confirm it's a pneumothorax. What are the two things we can go looking for that say this patient has a pneumothorax? The two things we can do, somebody had mentioned this earlier, we can go looking for a lung point and we can go looking for abnormal curtain signs. Okay, so we're going to cover those two things next. We're going to cover the lung point and abnormal curtain signs. So here's a nice example. This is a CT. So you can see this is our spine here. There's our heart. This side over here, I got a rib fracture right here. I got some contusions in the lung, but no pneumothorax. On this side of the CT, I can see I've got a pneumothorax. So this area outlined in red by the little dot, this is a pneumothorax. Down here, I've got lung, okay? Now, here's my first question, team. If I put the probe on the chest at site number 1, am I over air-filled lung or am I over the pneumothorax where this probe is located? So I am over pneumothorax here. So what will I see at this location? Will I get lung sliding or will I get an absence of lung sliding? If I put the probe here, I will not see lung sliding. I am over pneumothorax here, so I will see an absence of lung sliding. I'll just see my normal bat sign. I'll see A lines like you see in this image here. There's an A line right here. But I don't see any lung sliding. This patient has a pneumothorax, okay? What if I put the probe down here? Am I over lung or over pneumothorax? Down here, I'm over lung. And even though this patient has a pneumothorax, it will still breathe. Therefore, the lung will still move. Therefore, there will be lung sliding. What will I see here then? I will see normal lung sliding. And because this is a patient that's been hit by a car, the odds are I will also have contusions. I will have some B lines. So down here, I see the movement and I see the B lines. No pneumothorax down here. Excellent. Now, what about right here? When my probe is placed right here, what do I see? So right here, you can see that I'm over the pneumothorax to start with. No lung in my ultrasound image, right? So this is expiration. However, when my patient breathes, even though I start out over pneumothorax, the lung will slide into that image. And that creates lung sliding. That is the lung point. The spot where you start out with a pneumothorax and then the lung recontacts the chest wall and becomes visible. What does that look like? The punto pulmonar. I like it. So what does it look like? Here you go. We're over pneumothorax. Patient breathes, lung becomes visible. And it goes to the yellow arrow in this case, right there. So always an absence of lung sliding up here above the yellow arrow. Below the yellow arrow, there's the pneumothorax to start with, but as my patient breathes, the lung slides into my image right there. This is the lung point, the site where the lung recontacts the chest wall. We moved from an area of no lung sliding to an area where lung sliding becomes intermittently visible, okay? So in this case, the lung sliding confirms the pneumothorax because it is the lung point, okay? Now, most of the time, when we see patients with pneumothorax, most of those patients have concurrent lung contusions because it's a trauma that causes the pneumothorax. So in this patient here to the left, we don't see B lines. We just really, or we don't see good B lines. We see mostly lung sliding, okay? If the patient's hit by car, when we get to the lung point, we often see these vertical white lines when we see the lung point. So up here to the right of the rib shadow, just over here to the right of the rib shadow, we have pneumothorax all the time. No lung sliding, no B lines visible. On this side, we have pneumothorax here to start with, but then the lung sliding in and taking out the pneumothorax. And when I see the lung, because it has concurrent contusions, it's a hit by car pneumothorax, I see the B lines when I see the return of lung sliding. So this is an easier one. This is the lung point. Normally, like I said, we start at the most sensitive spot. We start at that caudal dorsal site, no lung sliding present. Or we suspect the pneumothorax. We don't see lung sliding at the most caudal dorsal site, we suspect pneumothorax. Our patient's not trying to die, so we have time to look for things that confirm a pneumothorax. And where do we move the probe? From the site where there's no lung sliding. If you put pathology in the pleural space, it squishes the lung around the hilus. The hilus is sitting down here. So it squishes the lung this way. So we move from an area of no lung sliding towards the elbow to see if we can identify the lung point, the return of lung sliding. Okay, hopefully that makes sense to you guys. That's what we'll look for. So in the tachypnic patient, there was a question. It becomes difficult to identify a pneumothorax in the tachypnic patient. And this is true. The faster the breathing, the harder it is to see the lung sliding. But if we get to this patient's breathing fast, this guy here with the lung point, if you get B lines in a patient with contusions in a pneumothorax, even if they're breathing quickly, because it creates this vertical edge you're seeing with a lung that has contusions, you can still see it. So hopefully that answers your question then. If they have B lines, even if they're breathing fast like this guy, you can still see the lung point because you go from no B lines to B lines, and you can see that no matter how fast they're breathing, okay? All right, sometimes we miss the lung point. So I'll just mention this one real quickly, because sometimes we're actually at the site where we don't see lung sliding. We're at the caudal dorsal site in red here. And we don't move to exactly where we see the lung coming in and out. So right where my dot is. We don't get that spot. We start out in the area of no lung sliding and we slide towards the elbow and we miss the actual lung point. We end up coming down to a point over lung. So we go from pneumothorax to lung sliding, okay? And we miss the actual point in between. That's okay. If you get a patient, you suspect a pneumothorax and you see this in the caudal dorsal region, no lung sliding. And you drop down and now you see lung sliding, especially with B lines, back up, nothing, back down, lung slide, no lung slide, lung slide, then the odds are you're just missing the lung point, but you should still tap this patient if the history and clinical findings supported pneumothorax, okay? So we don't actually have to always find the exact point where the lung recontacts. We're going from pneumothorax to lung slide to pneumothorax to lung slide, okay? Hopefully that makes sense as well. All right. And normally, if you think about where a lung moves the most, it's usually easier to find lung sliding caudal dorsally than it is cranial ventrally. We usually get more lung sliding up here than we do down here, okay? All right. Now, one other thing we can look for to help us rule in a pneumothorax, the abnormal curtain sign. So like we said, in a healthy patient, you'll come back, you'll find that caudal border. You'll see that nice vertical edge artifact, which is the curtain sign. We've talked about that in our normal patients. We can also, in patients with pneumothorax, find things at the curtain sign that suggest that truly is a pneumothorax, okay? And this again involves starting over lung, sliding back till you find that curtain sign, and then assessing that curtain sign in the area where you would have a pneumothorax, okay? And what do we see? So let's look at a normal curtain sign again, okay? So we're just gonna look at this for a second. We got a nice vertical edge artifact. So do you see this vertical edge artifact, which is the curtain sign? The answer is yes. I got air-filled lung here to the left. I got soft tissues of the abdomen to the right, okay? Now, when my patient breathes, does the curtain sign and the abdominal contents move in the same direction during inspiration and expiration? So here I am here, my patient breathes in, inspiration, expiration. Inspiration, expiration, inspiration, expiration. When my patient breathes in, the curtain sign moves caudally on inspiration. The lung slides into the costophrenic recess and moves or expands caudally as my patient breathes in. That makes sense. The diaphragm contracts and moves the abdominal contents caudally as well. So although one's moving faster than the other, the curtain sign moves faster than the abdominal content. They both move caudally on inspiration and cranially on expiration, okay? And the other thing is, I can always see the edge of the lung right here, overlying the soft tissues. So I have one air-filled lung to soft tissue interface, causing a vertical edge, okay? That never disappears. It might slide under a rib and I can't see it, but it's really always there because there's always lung overlying those soft tissues of the abdomen, okay? So here we are again, the normal's on the left, normal curtain sign, okay? On the right, this is the spleen that we're seeing here. I got a vessel right here where my dot is. Watch what happens when my patient breathes, okay, in the example to the right. On the left, everything's moving in the same direction during inspiration and expiration. On the right, watch what happens. Patient breathes in, the vessel moves caudal. Patient breathes in, vessel moves caudal. Patient breathes in. Now, the abdomen, the contents of the abdomen, because the diaphragm contracts, move caudal on inspiration like they're supposed to. What happens to that vertical edge, which is the curtain sign? It should move caudal with the abdominal contents on inspiration. It doesn't. It moves cranially. It moves in the opposite direction of the abdominal contents during the phases of respiration, okay? That's what we call an asynchronous curtain sign. So I put my line here in a normal animal, inspiration, expiration, inspiration, expiration. You can see they move in the same direction during the same phase of inspiration and expiration. This one here, I put the line down, the abdominal contents move caudally on inspiration like they're supposed to, the curtain sign moves cranial on inspiration, which it shouldn't do, okay? This is an asynchronous curtain sign. It looks like somebody playing the accordion. They're not moving in the direction they should, okay? That's an asynchronous curtain sign. And we will see that when we slide into the region of a pneumothorax along that caudal border. Okay. How about this one here? Again, we got a normal patient on the left. There's a rib shadow. There's my rib. There's the rib shadow. There's my rib. First white line below the ribs that joins the rib shadows. That's my pleural line. So I can see it to the left here. That's my pleural line. And this is my pleural line here. Then I get the abdominal contents. There's my curtain sign. And when my patient breathes in, if I put my little red dot there, I can see that on inspiration, expiration, inspiration, expiration. That vertical edge moves caudally on inspiration with the abdominal contents. And I always see it. It's always visible right there, one vertical edge. If I look carefully enough, I can also see that there's lung sliding or a shimmer right to the curtain sign. So I have lung sliding visible, a nice shimmer. I also have one vertical edge artifact, okay? So I can see the curtain sign. I only have one vertical soft tissue air interface, and that vertical edge is visible all the time throughout inspiration and expiration, moving in sync with the abdominal contents. What about this one, team? You guys tell me, is this normal or abnormal? What do you guys think? Does it look the same as the one on the left, or does it look abnormal? What do you guys think? I'll wait for somebody to say it looks normal or it looks weird. Abnormal, perfect. So if I look at this, this is really abnormal. I'm looking at this thinking I can see everything beautifully on the left. I look at this, there's nothing. Then there's something. Then there's nothing. So I'm just going to put this back into my normal arrow. And I'll pause this and I'll track it. So if you watch this, and I track this back, we'll see soft tissues of the abdomen there, nothing. So it'll go from seeing absolutely nothing in my image, no visible structures, this is a pneumothorax with no lung sliding, to all of a sudden, instead of having a vertical edge that moves, it just suddenly appears right dead center in the screen. So right there, soft tissue suddenly appear right here. And I've got air to soft tissue here and soft tissue to air here. I've got a pneumothorax on either side of these soft tissues that you can see. So I'll put that back into play mode for you, and you can see that this actually suddenly disappears dead center in the middle of the screen. So here we are again. I'll draw the lines. There's our normal line between air-filled lung, soft tissues of the abdomen, curtain sign on the left. Here are two soft tissue air interfaces on the right. And what happens with the actual curtain sign on this one? It suddenly appears and disappears dead center in the screen, okay? So what does that look like when we got that dead center? To me, this is like a peekaboo sign. It's like suddenly it's there and it's not. Peekaboo, peekaboo. So this is what we call the peekaboo sign. So I'll just play that one more time. We'll just go back and I'll show you that one more time on the double curtain sign. So to me, this is easier to diagnose than looking for lung sliding, okay? Oops. So this to me is easier to diagnose than lung sliding. And the other thing that's really nice on this, if the patient's breathing really fast, I can use the freeze button and then I can slow down the curtain sign and assess it. I can't do that with lung sliding because lung sliding has to be in real time to see the shimmer. If you freeze it and track it, you can't see the shimmer. I can freeze and track this. I can slow down the curtain sign and say, yeah, they're moving together, or nope, it's asynchronous, or nope, it's a double curtain sign. So that's the double curtain sign team. Now, somebody had asked about pneumothorax and M mode. So I put these in during the break while we were getting that presentation. I put in M mode. So what does M mode tell us? This is more challenging in dogs and cats than it is in people, but we do sometimes use it. And I do have a nice video of it here. So I'll just show you real quickly what M mode does. So M mode is motion. It actually picks up regions or structures that are moving. The pleural line, if the lung's against the chest wall, you will see the movement of the pleural line with M mode. So you'll see lung sliding with M mode because there's motion. So what should you see? So on this situation, the entire ultrasound image. What do you see? They call it a barcode sign. It's just horizontal lines with no evidence of movement, okay? So that is a pneumothorax. When your patient's breathing, what you'll do is you'll get no movement between the skin and the pleural line. But because the lung's sliding along the pleural line, in a patient that has the lung against the chest wall, it gets all blurry like this. This is called a seashore sign. And what happens is you get a barcode with no movement above the pleural line, but because the lung slides along the chest wall, you get motion below the pleural line. So no motion anywhere because there's no lung against the chest wall. You don't see any motion. Here, you see the motion. And the patients that are breathing slowly, every time he takes a breath, you'll see the motion. You'll lose the motion where he's not breathing. So when he's not breathing, there's no motion like this to the left. And then he breathes, you see this motion. So this is pneumothorax on the left. This is rapid shallow breathing in the middle, slow breathing to the right. What's it look like in real time? Here you go. If I look at this, you have no evidence of movement above the pleural line. Now I see all this movement and shimmering below the pleural line. This is a patient that does not have an pneumothorax because I can see movement below the pleural line. Okay, that is your M mode lung sliding a pleural glide sign. So this is a glide sign in a patient that does not have a pneumothorax. The lungs in contact with the chest wall because I see the motion below the pleural line. What does it look like with pneumothorax? This is your pneumothorax. Looks essentially like no movement. Got to keep in mind that you occasionally see something and you're like, well, wait a second, Boysen. Why is this down here not going to be motion? So I'll just pull this across. And if you look at this, you'll say, well, that looks like motion to me. This is motion, but it's motion, if you look at it, that originates above the pleural line. So in a patient with pneumothorax, when he tries to breathe, you'll sometimes get movement of the intercostal muscles, which you can pick up above the pleural line, which are reflected below the pleural line. So the biggest thing with M mode is you have to be able to differentiate muscle movement, patient movement, probe movement from pleural line movement. And that's why we often don't use M mode, because it's sometimes difficult. But here's a nice example again, in a patient that does not have a pneumothorax compared to a patient that does have a pneumothorax. No pneumothorax, pneumothorax. Okay. So just for you, those of you that were curious and will ask the question, that's the difference. Hopefully that clarifies it for you. Okay. All right. So in summary, we're finished with pneumothorax. We got one more section to go. That was the tough one. So now you're all thinking, man, that's tough to be taking a pneumothorax. We're going to finish on something super easy. We're going to come back to consolidations, which I think are fantastic to diagnose and much, much easier than pneumothorax. But in summary, B lines rule out pneumothorax at the site the probe is located. So at this probe site, at this location, do you guys see B lines in this ultrasound clip? Yes or no? I'll wait for somebody to answer just to make sure I know everybody's paying attention. Excellent. I see lots of yeses and C. So this says we have B lines. Therefore, there is no pneumothorax at this probe location because you guys saw the B lines. Excellent. Lung sliding. In this image here, do you guys see lung sliding at the pleural line? Yes or no? I see everybody saying yes. So I agree with you. We have lung sliding here. So again, this patient does not have a pneumothorax. And because I have lung sliding visible, I can assess this patient as normal or abnormal at the lung surface. I don't see any B lines. This patient's normal. Excellent. If I don't see lung sliding, like in this guy here, I should suspect pneumothorax. If the history and clinical findings fit and your patient's trying to die, he's really dyspneic, just go ahead and tap him. Okay. If, however, your patient's sufficiently stable, we should go looking for rule-in findings. One of those is going to be the return of lung sliding. This is return of lung sliding. This is a lung point. It looks a lot like the double curtain sign, but it's not because it's lung and has B lines in it. This is return of lung sliding. It can look very similar to the double curtain sign. This is a lung point. This confirms pneumothorax, okay? Return of lung sliding. And you will see B lines in injured lung, okay? This is the abnormal curtain sign. And if you look at that curtain sign, team. Is it normal or abnormal? It's playing peekaboo with you. It's there. It's not there. Wait, it's there. No, it's gone. No, it's there. Damn, that's a double curtain sign. I will tap this guy based on that double curtain sign. Again, if my history and clinical findings fit, because this is just really abnormal. Okay. All right, cool. So that was pneumothorax. Does anybody, just before I move into the last section here, I'll just check the time and see where we're at for time. So we are looking pretty good. We got some time left. We started at 11, so we got half an hour. So this should work out perfectly. Looks like nobody's got any questions at this point. We're all good. All right.
Doctor
Oye.
Boysen, yes. Rebeca Mendoza se dice el signo de cortina. ¿Puede volverlo a explicar, por favor? No lo entendí.
Okay, so the curtain sign, when we have a normal patient, I'll just play this here again. So I'm going to show you the normal curtain sign. And this is in our textbook. So there is an explanation in the book that we wrote, the pleural space and lung ultrasound. This is also available online. This is the abnormal curtain sign that's in Frontiers. It is open access. So I would also encourage you to find this paper and you can read the paper as well. But the abnormal curtain sign. This is a normal curtain sign, okay? So again, I'll just go through this one more time because it can be challenging. This is the normal curtain sign. When you slide the probe caudally on the abdomen, so you're half over lung, half over soft tissues of the abdomen, in a healthy patient, this is what you should see. You should see lung sliding here. You should see a vertical edge between air-filled lung and soft tissues of the abdomen, okay? That vertical edge is our normal curtain sign, okay? And it will move, if I put the red dot here, the vertical edge moves caudally on inspiration and cranial on expiration, okay? And if I look at that, inspiration, expiration, inspiration, expiration, inspiration, expiration, inspiration, inspiration, expiration, inspiration, expiration. This moves caudally on inspiration, cranially on expiration, okay? And it moves in the same direction as the abdominal contents. So here's the kidney, moves caudal on inspiration, cranial on expiration. The curtain sign, the vertical edge, and the soft tissues of the abdomen move in the same direction during respiration, okay? And I can always see the end of the lung in a normal animal, overlying soft tissues, okay? Never disappears. We have the asynchronous curtain sign, where if I put the red lines in, these are actually red lines coming nicely. If you look at this now, and I've drawn the red line, on the left, in the normal patient, when my patient breathes in, inspiration, the lung slides caudally into the costophrenic recess. So the lung moves caudally on inspiration. The diaphragm contracts, therefore the abdominal contents moves caudally on inspiration. It's all moving in the same direction. The vertical edge and the abdominal contents move in the same direction on inspiration and expiration. With the asynchronous curtain sign, the diaphragm contracts and the abdominal contents move caudally. I can see abdominal contents like this, it should go caudally. It moves cranially. So they move in opposite directions, okay? So that is the asynchronous curtain sign. With the double curtain, what happens here is I can see a normal patient here on the left. I see a nice vertical edge. It moves caudally on inspiration. It moves cranially on expiration. It moves in the same direction as the abdominal contents with the phases of respiration. Okay. What also happens there is when you get a double curtain sign, you will lose the visibility of the soft tissues. So right here, I put my probe right in the middle. There's never lung sliding here. Look closely right here. You'll never see lung sliding here. You'll never see lung sliding here because I am over a region of pneumothorax. And what happens when you get an abnormal curtain sign, the abdominal contents, because there's no lung between the chest and the abdominal contents at the costophrenic recess, the soft tissues pull sideways. So this is the liver of the abdomen suddenly popping into a pneumothorax. We see that because there's a pneumothorax and no lung separating the soft tissues from the chest wall. So this is a double curtain sign. We see two soft tissue air interfaces and the soft tissue just suddenly appear. So what you do is you come caudally and you check the curtain sign. This is normal on the left. And if you see this is really, really abnormal on this image to the right. The soft tissue is just popping in. This is the curtain sign, but it's a really abnormal. This does not look anything at all like this. Okay, so that's the double curtain sign. That's our pneumothorax. Okay, and if we summarize it again, come back to this slide, and we look at this one. Come back to this slide, and we look at this one again. This one right here. There's our curtain sign. Does that look normal? Inspiration, expiration. Inspiration, expiration. The whole thing looks like it disappears and comes back. So again, this is like a peekaboo. The soft tissues are just suddenly peekabooing into the image. Okay, so hopefully that makes sense, but if it doesn't, please send me an email. Take a look at that paper that we wrote, because it does explain it, and there's more videos in there. And I can also actually send you some more information. I do have some other clips that I can show you of normal and abnormal. So I did put a quiz of about 10 clips together. I don't have time to show you that today because we're going to run out of time. But if you're really, really keen and you want to see more abnormal curtain signs versus normal, just send me an email and I will share those clips with you. Okay. All right. Hopefully that makes sense though. Any other questions, team? Pneumothorax is the hardest to diagnose by far. Any other questions, team, before we move into our last section? I promise this is easier. All right, let's go into the last section. We're going to talk about lung consolidation, team. Now, this one's really interesting. Detecting lung pathology. We said you can detect lung pathology two ways. We can see increased B lines, which tells us there's something abnormal, or we can see lung consolidation, okay? What determines if it's B lines or consolidation that we see when we put a probe on the chest to look at the lung for pathology itself, okay? What determines if we see B lines or consolidation? Simply put, it's the percentage of air at the lung periphery below the probe. So how much air is there in the lung at the lung surface where we put the probe? That's what tells us if it's B lines or consolidation. How much air is in the lung at that probe location, okay? So if we have more than 10% air in the lung at the site we put the probe, we will not see the lung. As we said, air is an enemy of ultrasound. How much air has to be present for us to reflect the beam back to the probe and prevent us from seeing the lung? Anything, according to the human literature, more than 10% air in the lung, even though it's much lower than normal, still is enough enemy to bounce the beam back to the probe. So anything over 10%, we're not going to see the lung. We will, however, start to see B lines develop at the lung surface as the percentage of air drops. But we still don't see the lung as long as that percentage of air is more than 10%, okay? So here you see increased B lines, but I don't see the lung itself. I see artifacts at the lung surface that tell me there's pathology in the lung, okay? Once that percentage of air falls below 10%, I now no longer have an enemy. If you take all the air out of the lung, what are you left with? Take the air out of the lung, what's left? Soft tissue. The lung is soft tissue. Take all the air out, you're left with soft tissue. What does it look like? It looks like tissue. So when you get below 10% air in the lung, the ultrasound beam is no longer bounced back at the inside lining of the chest. It goes through the lung itself like it's tissue, because if you remove the air, there's no more enemy in the lung, it becomes tissue. Okay, so that's the difference. As long as I have enough air in the lung, I can't see the lung. I have to interpret pathology in the lung through B lines and surface artifacts. Once I get below 10% air in the lung, no more enemy there. I can now interpret the lung itself because there's no enemy. I see actual lung tissue. All right, let's go through that in more detail. Here is fairly normal looking lung on this x-ray. So I look at this x-ray, this is an x-ray of a dog. And I see it looks pretty normal up here in the caudal dorsal region. It starts to get a bit more abnormal here, a bit interstitial. And then down here, I got real pathology. I got alveolar pattern down here. So I'm going from normal to diseased. What do I see up here in the fairly normal region? Well, a normal aerated lung, it's more than 85% air. So if I put the probe on a normal patient, I have more than 85% air at that site. That's the enemy of ultrasound. I can't see the lung. What do I see? Nice lung slide. So this over here to the left is what you will see in a patient that has normal aerated lung, just lung sliding. Maybe one B line, but not a lot of B lines because we don't have any decreased aerated lung. It's healthy. What happens when I get down here into this interstitial region? In this situation here, the percentage of air is less. What happens when the percentage of air drops? B lines become visible. But I don't see the lung itself because I'm still over 10%. So between 10% and 85% air in the lung, B lines develop. The lower the percentage of air, the closer I am to 10%, the more B lines I will see. But I still only see B lines because there's still enough air in the lung to bounce the beam away. Okay, so that's what I see here. But what happens when there's so little air in the lung, the ultrasound beam no longer is bounced away from the lung surface. In that situation, I start to see the actual lung itself. That's like this alveolar pattern. So over here to the left, this is lung tissue right here. The beam's not being bounced back at the lung surface. The beam's going through the lung because there's no enemy there. This is lung tissue. That happens when there's less than 10% air in the lung. That's why I love lung ultrasound. Super simple. You got aerated lung with enough air, all you see is the lung surface. We look for B lines. If the air falls too low in the lung, we start to see consolidations. It's that simple. So this is a really nice example of that. In this images here, we got 3 different videos. In this video up here, we've got the ultrasound probe on the dog with aspiration pneumonia. And we're going to go from a fairly normal region to an interstitial pattern to an alveolar pattern. This ultrasound probe will slide down towards the elbow. In this radiograph, we'll put an ultrasound probe here, and it will slide in sync with the ultrasound above across normal, interstitial, and alveolar. And what do we see as the probe moves from normal to abnormal? You'll see that here on the right. This is all synced together. And we're going to move from normal to interstitial to alveolar. Okay. And we're going to play all 3 together. So here we go. We're on fairly normal looking lung. I am an aerated lung. I don't see any B lines, maybe one. Nice lung sliding. I get to interstitial. The percentage of air starts to drop. I get down below 10%. I move from B lines to consolidation. Okay. So we'll play this 2 or 3 times just to make sure we get the translation correct. So here we are on nice aerated lung, no B lines. I move into an area with less than 85% air, B lines become visible. They're still visible, and I don't see lung tissue because I'm above 10%. When I fall below 10%, I get lung consolidation. Okay, so we'll play that a 3rd time just to show it one more time. Normal aerated lung, nice lung sliding, no real B lines, maybe one. Less than 85% air, B lines become visible. They get more and more numerous as I get less and less air, and then I fall below 10% air. Boom, I see consolidation. Now I see the lung itself looking like soft tissue. Okay, does that make sense, team? I think that's just a really nice way to show the difference depending on how much air is in the lung, moving from healthy to consolidated. Okay, so that is our lung consolidations. Now, there are 3 criteria if we see actual tissue represented as lung. No enemy of ultrasound, not enough air to bounce the beam. There are 3 criteria we look for. Okay, what are they? All consolidations should look for or arise from the pleural line. So lung consolidation should arise from the pleural line. So we got to look for that pleural line. Like we said earlier, all things arise from the body of the bat, from the pleural line. Should have a tissue pattern. That makes sense. No enemy. What are you left with? If there's no air in the lung, you're left with soft tissue. It looks like liver, so it has to have a tissue pattern. And it's going to have distal boundaries. And these ones here, this distal boundary, is how we classify the different types of consolidation. Okay. So you guys asked in this case, what was the cause of consolidation? So, sorry, my bad. In this case here, what was the cause of that consolidation? This is aspiration pneumonia. So this is a dog that has aspiration pneumonia. And you can see on the X-ray, we've got an alveolar pattern. This is consolidation. So this is aspirated gastric contents with aspiration pneumonia that's causing those B lines. So good question, Juliana. That is lung consolidation. Secondary, this patient has aspiration pneumonia. Okay, so let's look at these 3 criteria. Should arise from the pleural line, should have a tissue pattern, has to have a distal boundary. Okay.
Un patrón tisular y debería tener un margen. Debería entonces nacer de la línea pleural. En este caso, tenemos un gato con masa pulmonar. Y lo que tenemos
wall with air, okay? So this is a patient where if I put the probe on, I will not see that mass, correct? I'll just see a normal lung sliding with an A-line pattern. Now, if you look at this image to the right, some people would look at this and say, well, there's my pleural line right here. If this is below the pleural line, could this be a mass? Could I have a mass right here? Is this vessels in a mass below the pleural line? And the answer to that is no. This is not a mass. And how do I know that? I have to watch it in real time. If I see lung sliding, then the only thing that I can really look for is at that lung sliding, I need to see a shimmer, and then I can look for B-lines. But if you have a shimmer present, then we usually don't have lung consolidation visible. So if I watch this and I think, wow, could that be a mass? I look at this. Here's the lung sliding. Can you all see the shimmer in the sky? And this down here is a mirror image of things above. So just like at the diaphragm, soft tissue air interfaces create mirror image. So when I see lung sliding, I know I've got air visible at the lung surface, which means I'm going to see mirror image. So if I have lung sliding visible, it's bright white, and I see a shimmer, I look for B lines and I ignore everything else because it's going to be mirror. Okay. So here I see lung sliding, I don't see B lines, which means this is mirror image below it. So if I see lung sliding, I look for B lines. I do not look for anything else because it looks like this might be tissue down here. It's not, it's mirror image because the tissues above get reflected below. Just like the liver at the diaphragm, it's reflected on the other side of the diaphragm. Okay, so this here is mirror image. So if I see lung sliding, I look for B lines, but I don't interpret anything other than B lines because this is going to be mirror image down here when I see the lung sliding. Okay, so the other thing it needs to have is a tissue-like pattern. So if I look at this guy, this one here, I see lung sliding over here. I do not see a soft tissue air interface here. So this is not mirror image because I don't have lung sliding here. I actually have soft tissue opacity here. So this is true and it moves in sync with the lung sliding. This is consolidation, okay? This one's real. How do I know that? I don't see the lung sliding here. So therefore it's not mirror image, it's real. It goes soft tissue to soft tissue down to this line here, okay? So this is lung consolidation. So it has to originate from the lung surface whenever we have consolidations, okay? And over here, nice lung sliding, therefore there's mirror image, no consolidation. Here, that's real, okay? And it has to have a tissue-like pattern. So if I look at this image here, this is the diaphragm. It's curving away from the chest wall. Why can I see it curving away from the chest wall? Because the air in the lung has been replaced with cells and aspirated content. This is consolidated lung here. The ultrasound beam comes through, does not encounter an enemy. It's not air-filled lung. Therefore, it goes through the lung from surface to surface like it's tissue, allowing me to see the diaphragm curve away from the chest wall. Okay. This is liver on this side of the diaphragm. Look how similar consolidated lung looks like. Liver, consolidated lung. This is why they call it hepatization. It looks like the liver. This is consolidated lung. It has a tissue-like pattern. And the more severe it is, the more liver-like it looks, okay? So this is consolidated lung. This is liver, okay? Has a tissue-like pattern. And the third one is, what does the distal border look like? This tells us the different types of lung consolidation, okay? So it has to have a distal boundary. So this is, again, not rocket science. If the ultrasound beam is at the, or the ultrasound probe's at the surface, the ultrasound beam comes through the subcutaneous tissues. It goes through the intercostal muscles. If there's no enemy of ultrasound there, there's no air in the lung, less than 10% air in the lung, that ultrasound beam goes through the lung. And it'll go through the lung until one of two things happens. This is simple. If you don't have air in the lung, the ultrasound beam goes through it. It will continue through the lung until one of two things happens. Either you've gone all the way through the lung and never got aerated lung again. It'll go surface to surface, covers that entire lung lobe because it never re-encountered aerated lung. Surface to surface consolidation. Or you re-encounter a region of lung below the consolidation that has 10% air in it. Then the beams bounce back to the probe at the new soft tissue air interface. So in this situation here to the left, does the consolidation go all the way through? No, it stops right here. Why did it stop right here? Because once I got here, there is more than 10% air below the consolidation, okay? Only two things can happen. It either goes all the way through or it re-encounters a region with air in it. So this is partial consolidation because we re-encounter a region of lung with air in it, okay? On the other one, no enemies encountered. So the ultrasound beam comes through, goes through the subcutaneous tissues, the intercostal muscles, no air in the lung. What does it do? Starts going through the lung. What happens? One of two things. It either goes all the way through to the other side, like you see here against the diaphragm, or it encounters aerated lung. And in this case, we don't get any aerated lung. This is surface to surface or translobar. Same thing if I put pleural fusion in and I collapse the lung. Ultrasound beam comes through, skin, subcutaneous tissues, goes through the fluid, hits the lung surface. It's going to go all the way through, or it's going to encounter a region of aerated lung within the lung tissue. This case, no aerated lung encountered, surface to surface. Okay, so that is translobar. All right. All right, so that's the difference. Now, we've got two types of partial. So if I look at the image here to the right, let's just look at this one to start with. Do you see lung consolidation? Yes. It's not just felines. I can see the actual tissue of the lung here. Does it go all the way through, or do we lose it? So it does not go all the way through the lung. So this is partial lung consolidation right here. Now, your next question, if it's partial, you ask the question, does the border between the lung that's consolidated and the aerated tissue below it, is it smooth and well-defined, or is it regular, irregular, poorly defined, and not easy to see the difference between the lung and the aerated tissue? So in this case, very poorly defined. I don't know exactly where the lung tissue ends and aerated lung begins, okay? So in this situation here, this is partial lung consolidation. This is a shred sign because the transition between consolidated lung and aerated tissue is poorly defined. So this is a shred sign. Nodule signs, again, same situation. Look at this. Is there a tissue sign? Yes, I can see actual tissue. Does it go to the far field? No. Therefore, it's partial. Now look at the border between the consolidated lung and the aerated lung around it. Is it irregular, jagged, and poorly defined? Or is it well-defined, smooth, white, and rounded? This is smooth, white, and rounded. This is a partial lung consolidation and a subcategory of a nodule.
Una subcategoría de nodular. Este sería un nódulo en sí. Así que la diferencia entre signo shred o de picado o un signo modular. Irregular, borde pobremente definido.
As opposed to translobar, where we can see surface to surface. So here's the surface of the lung. I go all the way through. I don't encounter any air. I see the far wall of the lung. This is a translobar, surface to surface lung lobe consolidation. Okay, so that's the difference between shreds, nodules, and hepatization. Okay. All right. So what causes lung consolidation, team? So it is essentially a progression of what causes B-lungs. Decreased aerated lung within the lung itself, especially at the lung periphery. So anything that decreases aeration in the lung can cause B-lungs. Make it severe enough that it falls below 10% air in the lung, you see consolidation. So consolidations are caused by the same thing as B-lungs. So we will see consolidations. For example, over here, we can see a shred sign. We can see that with blood. Put enough blood in the lung, no air left, looks like tissue. Pus, aspirated gastric contents, other fluids, ARDS, all these things will cause consolidation. Just like B lines, it can be non-fluids, cells, neoplasia, inflammatory, fibrosis. We can see consolidations with fibrosis. And then, just like B lines, we don't even need pathology in the lung. We can take the air out of the alveoli of a healthy lung, take enough air out, no enemy left. What do you see? Consolidations. We can see them with atelectasis. Severe atelectasis will cause consolidations. So just like B lines, you have to think about all the causes. Fluid types, cell types, atelectasis, all can cause consolidations, okay? All right, and then we're gonna put all this together. We're gonna map the lungs. These are called lung profiles, and we have a lot of them listed in the textbook that we wrote to try and explain what you see with different lung pathology. So if, for example, I see lung sliding in these images, up here I see lung sliding and just A lines. Looks fairly normal. This one looks fairly normal. This one looks fairly normal. I get to an area now where I start to have decreased aerated lung, I see B lines. And as I move more ventrally, I go from normal lung to B lines to consolidation. That's this patient's profile, and there's no pleural effusion. Now I can say, based on this pattern, this is most consistent with aspiration pneumonia. So I look at multiple sites, I map the lung surface and look at the pleural space, put it all together and come up with a profile, okay? So if I saw this patient here, for example, and this is the pattern I get, lung sliding up here, no B lines, looks fairly normal, 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 looks fairly normal. One spot where I have an area of partial lung lobe consolidation, I get a partial lung lobe here, but everything around this spot is perfectly normal. This isn't aspiration pneumonia. Aspiration pneumonia causes inflammation. It spreads from fairly normal to really abnormal. This one here, it's all normal around that one region with a partial lung lobe consolidation. Even though it's cranial ventral, based on the fact everything around it's normal, most of my plus profile is normal, except for this one region. This guy here suggests it's a nodule. So again, map the lung surface. Check to see what the areas around the abnormalities are. Is it perfectly normal, or does it transition from consolidation to B lines to normal? So again, map the lung. How that maps influences what your underlying cause is, okay? So our summary in lung consolidation then, when there's less than 5 to 10% air in the lung at the periphery, there's no more enemy there. The ultrasound beam can now go through the actual lung and shows up as soft tissue. That is lung consolidation, okay? There are 3 main types of lung consolidation. 2 partials. One is a shred sign, poorly delineated border between the consolidation and aerated lung, a partial consolidation. Nodule, a well-defined, often round, partial consolidation, like you see here to the right. And then there is hepatization or surface to surface within the lung lobe and also visible at the diaphragm, translobar hepatization, okay? All right, so in summary, this is the end of our lecture. We're pretty much right on time, but there are 3 key rules of pleural space and lung ultrasound, okay? You gotta know your borders. Pathology accumulates at the borders, and knowing your borders gets you to the most sensitive spots for pneumothorax and pleural effusion. You can use your borders to get to the caudal dorsal site. You can use your borders to assess that ventral pleural site, and you need to think about patient positioning and the pathology you're looking for. It changes. You look for different areas depending on how patient positioning is and where and what pathology you're looking for. So in the pneumothorax case, you're looking at the widest point of the chest, non-gravity. It varies between lateral and sternal. This is pneumothorax in a sternal patient. This is pneumothorax in a lateral patient. Different probe locations. Think about patient positioning and what pathology you're looking for, and then put it together and look for the most sensitive spots. It's not rocket science. It's common sense. Fluid falls, gravity rises. That varies depending on patient positioning. Okay. And when we're looking for pathology, it's going to vary depending on what you're looking for. Okay. When we're looking for pleural space and lung ultrasound, we're looking for pleural space pathology. We always start over lung. Okay. So you don't accidentally diagnose abdominal things for lung pathology. Start over lung. Come back and find that curtain sign. Once you find that curtain sign, decide, am I going to look for pneumothorax or am I going to look for pleural effusion? Pneumothorax, go to the most caudal dorsal site. Slide up along that curtain sign until you get to those sublumbar hypaxial muscles. So slide dorsal. That's where you're going to look for pneumothorax. If you're looking for pleural effusion, come back to the curtain sign, go down to the pericardial diaphragmatic window. Turn the probe parallel. Okay. Don't forget to include that subxiphoid site when you're looking for pleural effusion. All right. And this will change. We'll go after the widest point, the pericardial site, if the patient's lateral versus sternal standing. Okay. And then once we've ruled out pneumothorax, we know we can check multiple lung regions. So you can check multiple intercostal spaces in the dorsal, the middle, and the ventral third. We can scan the lung surface itself. Knowing that, pathology distributes a little bit different than radiographs. Aspiration pneumonia is similar to radiographs. It's a cranial ventral pattern. Congestive heart failure, in contrast, tends to be diffuse and bilateral. So we can see it everywhere. So you create those plus profiles of the lung, okay? Any questions, team? I've got my email here. The guy I usually do lectures with, he is in clinics today. He couldn't join us. That's Dr. Serge Chalou. You can send either one of us an email. We both contribute to writing the pleural space and lung ultrasound book that we talked about. But if you have any questions, please send me an email. I'm more than happy to look at any of your lung ultrasound clips if you have any. And if there's a chance to get down and do some labs either in South America or if you're in Calgary in Canada, let me know. Maybe we can get you into a lab. That would be fantastic. Send me an email if you have any questions. On that note, I'll turn it back over and stop the sharing.
Muchas gracias, doctor Soren, por como dicen aquí, muchas gracias, están comentando, muchas gracias, una muy, muy buena charla que dio usted. Aquí hay una pregunta. Dice, is there any signs of lobar torsion in ultrasound?
Yes. So lung lobe torsion is something we can. So that's the question. Are there any signs specific with lung lobe torsion? So lung lobe torsion can be a challenge to diagnose on ultrasound. One of the things we'll look for is pleural effusion and lung lobe consolidation. Within that lung lobe, when it's consolidated in torus, we often get what's referred to as a star type pattern. It actually gets a little bright white and black. So it has a bit of a parenchymal change, but it's not that sensitive. So we often look for pleural effusion. We see consolidation of the lung. That lung consolidation is often translobar, and then we have to put it together with the clinical findings. So a pug, for example, would be more predisposed to a lung lobe torsion. So the history and clinical findings will help us for sure. We can look for what's called that stellate lung pattern, which is a little bit unique to a lung lobe torsion, but not always visible. So good question, but that one can be a bit challenging.
Mm-hmm. In the chat, Pia also, Pia, ¿quieres realizar la pregunta en vivo o prefieres escribirle al doctor?
Ok, sí, ok.
Por favor.
Yes, in a pulmonary thromboembolism, which could be the findings if it reach the periphery of the lung?
So pulmonary thromboembolism, what signs do we see if it reaches the lung? So with pulmonary thromboembolism, there's two things that we often look for. One, we look for indirect evidence by assessing the heart. So with pulmonary thromboembolism, if it's large, we can see changes in the right side of the heart. So the right ventral gets enlarged, the right atrium gets enlarged, and the septums start to deviate. So we can see changes in the heart with massive pulmonary thromboembolism. What do we see as an actual change in the lung itself with pulmonary thromboembolism? In that situation, what we can actually see with pulmonary thromboembolism is a triangle shape. So this is an example of what we might see with pulmonary thromboembolism. Let me just pull up the share here and share that so I can show you what it is. So with pulmonary thromboembolism, what we can actually see is a triangular. So we see this wedge or triangle shaped lesion with a lot of pulmonary thromboembolism. You see example of it here. Now the problem is triangular shaped lesions can also be seen with neoplasia and other inflammations, aspiration pneumonia. So it's not specific to thromboembolism. What they do in people is they look for these wedge-shaped triangles, and then they go looking for deep vein thrombosis. And if they find deep vein thrombosis and triangular lesions in the lung in people, then it's very, very likely that it's thromboembolism. Our veterinary patients don't get deep vein thrombosis. So we can't confirm that there's another hypercoagulable condition to suggest that it's pulmonary thromboembolism. So how do we do it in our veterinary patients? If we see a triangular lesion, particularly if it's in the caudal dorsal region, which is unlikely aspiration pneumonia, that wasn't there the day before, in a patient that's predisposed to a thrombotic event. So if I have a patient that's an immune-mediated hemolytic anemia, and I have him on steroids, he's at risk for thromboembolism. If I scan that patient and I saw nothing in the lungs, and then the next day I see triangles in the caudal dorsal region, I'm going to suspect that that's pulmonary thromboembolism. The big problem we have is some aspiration or some other lesions, neoplasia, can be triangular. And the other thing is not all thromboembolisms triangular. Some thromboembolisms can look like shreds or have different shapes. So it's one of the things that we suspect. Look at the heart, see if there's changes in the heart that suggest it's a massive thromboembolism, suggesting right heart failure, and look at the history to make sure it's got a condition that suggests it's hypercoagulable, and then also look at the distribution on where you see those lesions. Are they one or two only in the caudal dorsal regions? Then I would suspect pulmonary thromboembolism. Unfortunately, it's not as specific in our veterinary patients as it is in humans, because of the fact our veterinary patients, which is good for us, our patients don't get deep vein thrombosis, which they have in people. Hopefully that answers that question.
Yes, thanks.
Muchas gracias, doctor. Thank you very much, doctor. El último comentario, or the last comment, is I had a patient with lung lobe torsion with a peripheral hypoec. I don't know how to pronounce it. I'm sorry. Hypoec.
Yep.
Band and a stellate pattern distally to the same.
The hypoechoic band. Yeah. So that's a patient that, again, based on what you're describing, would we see that, or potentially could we see that in a patient with a lung lobe torsion? Absolutely. It's that stellate pattern. If I see it, then I'm thinking, could this be a lung lobe torsion? So that's that stellate pattern that we often look for sure. We don't see it in every patient with lung lobe torsion, but if I see it in a breed and it has pleural effusion and it has findings consistent with a lung lobe torsion, then absolutely, Ernesto, we will look for that stellate pattern and that hypoechoic band for sure. It's just we don't see it in all of our lung lobe torsions, but that's a patient I would definitely have that on my list of differentials. You bet. Absolutely, Ernesto.
Muchas gracias, don Ernesto Weber, por la pregunta. Vamos a agradecerle, por supuesto, al doctor Boysen por esta charla que nos dio en dos partes, por supuesto, y también vamos a agradecer a Sebastián Richard. Él es el traductor de estas charlas de hoy, estuvo junto ahí en el canal en español para que le demos ahí su agradecimiento correspondiente porque lo hizo increíble. Muchísimas gracias, Sebastián, por la traducción. Y vamos a invitar también a la doctora Claudia Espinosa, por favor. Doctora Claudia Espinosa, puede, ahí está, por supuesto.
Sí,
por favor.
aquí estoy, Carla, súper atenta. Carlita, tenemos que ir con el videíto de los auspiciadores ahora.
Sí, es al final, usted hace el cierre y yo transmito el video para darle el cierre al doctor.
Ah, perfecto. Era al revés, le había explicado yo a Paula.
Ay,
pero...
discúlpeme, le envío, lo paso, no hay ningún problema, lo paso de inmediato.
Por favor.
Vamos
por
entonces
favor,
a pasar
gracias.
un video, yo había entendido al revés, vamos a pasar un video de los sponsors de este congreso y vamos a de inmediato. Denme por favor solo un minuto. para poder compartir.
Muchas gracias.
Ahí se puede ver la vejiga de la tortuga y hacia dorsal, aquí se asoma ya el ovario, donde se ven pequeños focos anecoicos, unos circulitos anecoicos. Esos son los folículos preovulatorios. Y acá ya vemos otros circulitos más ecogénicos, que son folículos también, pero estos ya están dentro del oviducto, ya salieron del ovario y están en proceso de maduración.
Ahí está, se me quedó. Está un poquitito pegada la transmisión, pero estamos aquí para poder entregarles a ustedes todos los auspiciadores de este 10º Congreso de Imagenología Veterinaria SOCHIRAV 2022. Denme por favor un...
Okay,
Cosas que
in the
pasan cuando están
meantime,
en vivo, sí.
thanks, Dr. Boysen, for your lecture. We are already receiving all the good comments from our colleagues. So thanks and till next time.
Until next time. Have a good evening, guys.
Bye.
Bye.
Muchas gracias, doctor. Vamos a ver qué fue lo que pasó. Voy a dejar de compartir para compartir nuevamente. Discúlpenme, estas cosas pasan cuando estamos en vivo, por supuesto. Tiene que haber sido un pequeño problema de... Ahí estaba justo compartiendo. Vamos a seguir compartiendo. Ahí vemos. Ahí sí. Ahí sí. Perdón.
En la actualidad, el desarrollo tecnológico ha alcanzado un alto grado de sofisticación, incorporando diversas herramientas disruptivas que hacen la diferencia al momento de diagnosticar a un paciente. Global Ultrasonido pone a disposición esta evolución al servicio de nuestros clientes y la sociedad a través de soluciones integrales y de vanguardia tecnológica para el área de imagenología. Nos convertimos en socios estratégicos y de confianza para nuestros clientes, integrando distintos aspectos desde lo técnico a lo económico para proponer juntos una solución integral a sus requerimientos. Nuestra misión es que nuestros partners estén a la vanguardia en equipamiento y conocimientos para ser parte de la élite mundial del diagnóstico. Avancemos juntos hacia el futuro. Únete a la innovación. Únete a la familia Global Ultrasonido. Global Ultrasonido. En la actualidad, el desarrollo tecnológico ha alcanzado un alto grado de sofisticación, incorporando diversas herramientas disruptivas que hacen la diferencia al momento de diagnosticar a un paciente. Global Ultrasonido pone a disposición esta evolución al servicio de nuestros clientes y la sociedad a través de soluciones integrales y de vanguardia tecnológica para el área de imagenología. Nos convertimos en socios estratégicos y de confianza para nuestros clientes, integrando distintos aspectos desde lo técnico a lo económico para proponer juntos una solución integral a sus requerimientos. Nuestra misión es que nuestros partners estén a la vanguardia en equipamiento y conocimientos para ser parte de la élite mundial del diagnóstico. Avancemos juntos hacia el futuro. Únete a la innovación. Únete a la familia Global Ultrasonido. Global Ultrasonido.
Medical Market, empresa líder en la venta de equipamiento médico, con foco en ecografía, rayos X y sistemas de digitalización, quieren ser parte de tu crecimiento. Pon atención a las siguientes promociones que son exclusivas para los asistentes de este congreso. Ecógrafo Sonoscape modelo E2 Provet. Cuenta con plataforma multipropósito y funciones Doppler color. Es el mejor equipo relación precio-calidad del mercado. Solicita tu demo. Equipo rayos X con digitalizador tipo CR. Toda la calidad de la marca Konica Minolta y un potente equipo monobloque de 5.3 kW se convierten en una solución de radiología digital a tu alcance. Pero si lo que buscas es lo último en tecnología, también contamos con digitalizadores de tipo flat panel. Consulta por las promociones vigentes. Y porque sabemos que la postventa es fundamental, te contamos que nuestra empresa es representante de cada marca. Contamos con servicio técnico propio y además es certificado mediante la norma ISO 9001 para el servicio de postventa. Si tienes mayor consultas, síguenos y contáctanos.
sí, vamos a dejar de compartir entonces. Voy a parar esto aquí para no interrumpir entonces la conexión. Ahora sí, doctora Claudia.
Sí, por aquí estoy.
Perfecto, ahora sí.
Perfecto, ¿me escuchan bien, no es cierto?
Yo la escucho perfecto, sí.
Ah, perfecto, solucionamos los problemas entonces de audio que tenía en la mañana.
Sí.
Bueno, estimados colegas participantes de este congreso, quiero agradecerles por la asistencia, por la paciencia también. Sabemos que hubo algunos desperfectos ahí técnicos, esperamos solucionarlos de aquí a mañana. Así que nada más que, primero que todo, agradecer al doctor Boysen también por su excelente charla, por haber aceptado la invitación, ¿no es cierto?, a participar de este 10º Congreso de Imagenología Veterinaria, al doctor Sebastián Richard también, que es colega nuestro, pero también se dedica a la traducción, que lo hizo excelente, se le entendió todo perfecto, también entonces agradecerle a él. Y bueno, solamente decirles que ha sido una jornada muy grata, una jornada muy productiva, espero que hayan aprendido mucho. Mañana nos vamos a estar encontrando nuevamente, ya el ingreso también va a ser entre las 9, 9:30 de la mañana. Tengan paciencia porque como son hartos participantes, de a poco se les va dando el acceso a la sala, ¿ya? Así que sin nada más que decir, invitarlos a la nueva jornada mañana en que nos va a estar acompañando la doctora Elizabeth Domínguez desde España y la doctora Guadalupe Ranea desde Argentina con interesantes temas nuevamente.
Así es, muchas gracias, doctora Claudia Espinosa, presidenta de SOCHIRAV, quien está siendo el cierre de esta primera jornada. Mañana los esperamos nuevamente, como ya nos dijo, y nos vemos en una próxima ocasión también. Que estén muy bien.